Welcome to the pre-Congress session of the 18th Annual International Congress of the Trivandrum Obstetrics Club. It's the 18th year I am standing before you, and it's indeed a delight to meet you all another year, and as always this year too. And we do have set an arena of insightful topics to learn and indeed to contemplate upon. Apart from being a doctor or a practitioner in the field of medicine, what I still cherish is the art of teaching and in fact learning. This very thought provokes me, rather bullies me in my sleep to program and to host advances every year. And I believe that I have done justice to my thoughts. As the proverb goes, well begun is half done. We have eminent faculty from abroad and all over the country, and to kickstart advances in the most exciting and galvanizing way. Wishing you the best of learning experience. Thank you. Have a great day.
Simon Cunningham is a consultant in fetal medicine, obstetrics and gynecology at Royal Stock University Hospital.
Thank you.
Over to you, sir.
Thank you very much for that introduction, and thank you very much for the privilege of speaking here this morning. I'm going to spend 20 minutes really just going through non-invasive prenatal testing or cell-free fetal DNA testing, which is very new, and first trimester anomaly scanning, really just showing how we're bringing things down and diagnosis down earlier and earlier in gestation. Okay, so what I want you to get out of this talk for your personal practice is really just understanding the prerequisites of cell-free DNA, why integration of the two tests is still necessary, why, although there's an option just to go straight for cell-free fetal DNA, an early ultrasound is still going to be necessary. I want you to understand the benefits and limitations of each, and really just take home 2 or 3 practice points from this, okay? Obviously, there's something on the Royal College website. It's chugging a bit. It's printed in 2014, but it's a very good introduction to cell-free fetal DNA testing. If we put it into context of the other modalities of testing for Down syndrome, we can see that triple testing at the start in the 1980s had a sensitivity of 60%. That's gradually increased, and now we see that with cell-free fetal DNA, for Down syndrome, there's approximately 99% sensitivity with a very low false positive rate. It's important to understand, though, that even if you come back with a high-risk result, that the positive predictive value, I lost my screen. Thank you. Is this working? Positive predictive value is still going to be 80%, so it's not a guaranteed diagnosis of Down syndrome. Can you see that? Thank you. There we go. Right. However, cell-free fetal DNA has made it possible, really, to test for something like 83% of chromosomal abnormalities seen in fetuses. Thank you very much. From 10 weeks onwards. Okay, so from 10 weeks now, we have the ability to test for these things. And also, it's throwing up a few challenges because it's allowing us to define the fetal sex, and also extending our ability to diagnose other things that hitherto we didn't really consider, like sex chromosomal abnormalities and microdeletions. So it is throwing up some ethical dilemmas as to which direction we want things to go in. I just want to go through some principles as to how it works. I'm not entirely sure what the level of knowledge is here, so we're going from basic principles. I need you just to understand that this is where the DNA is coming from. So it's the placental margin, and effectively that's got a half-life of about 20 minutes in the maternal serum. And it's 10% of the DNA in the maternal serum usually. That's kind of almost a prerequisite for the accuracy of the test. So how does it work? Well, if you can imagine that each chromosome represents a jigsaw puzzle. So say chromosome 19 is this jigsaw puzzle of Cinderella. And what it is that you've got millions and millions of jigsaw pieces which are unique and can be identified. And for the chromosome 19 ones, the database is able to match them as Cinderella. Not only that, but with shotgun sequencing, effectively, the jigsaw pieces aren't complete. There'll be a half of one or 3/4 of one, but the database is still able to match them as jigsaw pieces belonging to Cinderella or chromosome 19. So in that respect, you get a dilution. And you know, if for example, you've got a higher concentration of pieces of chromosome or DNA belonging to chromosome 21. And that's broadly how it works. There are a few other different techniques, but we don't have time to go through those, but that's essentially the principle. Okay. So it is cell-free fetal DNA, and that's confusing because it is actually placental DNA that we're looking at. And the reason it's important to remember that is you do get mosaicism, although rare, is more common with placental DNA than it is with fetal, which is extremely rare. As I said, it's reliant on the concentration of DNA for its accuracy. You need that kind of level to do the comparisons, and roughly a fetal fraction of about 8% will give you an accurate result. It can go down to as low as 4%, but obviously things begin to change at that point. And you need to understand that not everybody's going to get a result. Probably about 2 to 3% of people will need a repeat test. And I think, although the positive predictive value of Down syndrome is somewhere between 70 to 80%, the other abnormalities, it does drop off quite quickly. So for something like Turner's, it does drop down to something like 40 to 50%, or invasive procedures by about a third. We're doing current villus sampling now relatively rarely, less than 1 a month. After 2 rounds of training, our team still has trouble understanding what redraw and a priori risk mean. They're really confusing. Redraws, where we don't get a result initially, I think what we're beginning to see in the literature is that when somebody doesn't get a result and they need a repeat test, that in itself represents a higher risk of a problem. Our patient information leaflet had 10 drafts. You know, it went back and forth to patients, really just trying to get them to understand what. So it is quite some complicated principles to get across. You still need to do the scan. I think that's it. What's also happening is that we're now, as the test is being expanded and just widely distributed, we're seeing its effect in low-risk populations, which wasn't hitherto studied, and really just seeing how maternal age, BMI, and placental mass form an influence. We had to make a decision whether or not we're going to look for microdeletions at the start, and at the present time, we're not doing that. It is a consideration because at the same time, it will increase the counselling, it'll increase the amount of information that you have to give a patient prior to doing the test, okay? So, I think what this has told me is that we're not very good at either understanding or explaining risk. So, if we look at a priori risk and the effect it has on the same result, okay? So, a priori risk of somebody who's got, a woman who's got a risk of 1 in 10,000, even if she comes back with a high risk result for DNA, okay, then only 10% of those high risk results will actually result in Down syndrome. If somebody's got an a priori risk of, say, 1 in 100, third line down, then you can see that 91% of those high risks will come back with a risk of Down syndrome. And that is how, even though everybody says it's 99% accurate, that is how it's going to change the risk for the individual person. Okay. So if it is negative, because I mean, we often do the scan and then do the test, but in a lot of other systems, what we tend to see is that people have the test and then get the scan. So in that instance, if it does come back negative, what we then see is a fetal demise rate of 0.5%. We see people come back with multiple pregnancies of 0.7%. And also we still see increased NTs, okay? So it's not a guarantee of normality for your first trimester anomaly scan. And this is the point I'm trying to get across really. There's no separating the two. If we look at it, I'm just going to take you down the left side. So with cell-free fetal DNA, it's still coming into use in low-risk populations. We still need to know how that works. With twins, it's becoming increasingly commonly used, but that dilution we were talking about, that makes it less accurate. And again, we're still looking at how things work. It doesn't exclude the abnormalities. We're understanding how failed tests go. Only 8% of the global problems will be detected, and other techniques such as microarray are coming online as well. As their cost comes down, they may well supersede cell-free fetal DNA, particularly because they detect more abnormalities. First trimester anomaly scanning, on the other hand, we're looking at detecting something like 60% of anomaly scans now, with 10% of those only chromosomally related. It's helping us to predict unexpected findings, and it does increase the positive predictive value of a high-risk result from the cell-free fetal DNA if both things are pregnancy outcome. So there's away from the two things, and I suspect what will eventually happen is that these two guidelines will be merged into one. So if we're just briefly talking about first trimester scan, these are some of the things that you can see. I'm sure you're all familiar with these, so I'm not going to go through all of them, but like as we're expanding, we're seeing things like the mandibular gap, the small, just a small black area in the center of the mandibular when you scan. If that's absent, it's almost certainly, the baby's going to almost certainly develop micronathia. So we're getting better and better with technology, and our evidence base is increasing all the time. So I'm just going to go through a few things. You are limited, though, by fetal development. So you're not going to see problems with renal abnormalities. Cerebellar abnormalities, they are coming, but they are difficult to see. Cystic lung and diaphragmatic hernia, again, tend to occur later, and you won't see agenesis of the corpus callosum. If you're developing a workflow, then obviously these are some of the prerequisites. I would always encourage you to measure more than the crown rump length, all right? It will encourage I think you need to understand a little bit more of the embryology, and remember that sometimes things resolve, or we're seeing things that we've never seen before, and we're still not sure quite their natural history. I would always, as a first measure, turn the gain down. Okay, it will enable you to see the fingers, the mandible, the zygoma, and walls much better. Okay, so how low can you go? Well, if we can look at the graph, you can see there's a distinct difference between how much you see at 11 and 12 weeks. And you see that on scan very clearly, actually, in the definitions of the planes. And I think most of us would want to do a first trimester anomaly scan at 12 weeks or more. Okay? You can see the detection rates are improving. What also improves is the combination of transvaginal scan as well. It's not necessary for every patient, but it is worth getting into the habit of using it so that when you need it, then it's available, really. And in this way, we can now detect something like 78% of lethal abnormalities at an earlier stage than the second trimester. Okay, so nuchal translucency, I think you're all familiar with this, so I'm not going to go through it, but obviously you can see as it increases, it's not just about the karyotype being abnormal. We see an increased risk of fetal death and an increased risk of major abnormality. So by the time it's at 6.5, only 15% of fetuses will be alive and well. Okay. I'm going to concentrate on a couple of areas in the first trimester scan due to time. If we're looking at the calvarium, we can see the majority of abnormalities are going to be anencephaly and acrania, which are relatively easy to see, particularly at 12 weeks. The brain will still be present at 11 weeks. It won't have dissolved yet. Holoprosencephaly can have many variations, and again, some of those can be quite subtle and give the illusion of a midline and make it more difficult. Spina bifida, our expertise in diagnosing this is increasing all the time. So we're just going to go through a few things. This is your typical view. So we can see, I'm going to use them. Here we go. So we can see you've got your typical butterfly with the folks in the middle. It's nice and symmetrical. There's no ventriculomegaly there. And this is your typical view you expect to see with the diencephalon, the mesencephalon, coming down to the brainstem. This is the area we're interested in for looking for spina bifida. Okay. And that's just some of the embryology. And again, I encourage you just to read up, just have a cup of coffee, and just try and just understand how things will change and develop, because it's happening so fast at this gestation. If we look at holoprosencephaly, this is what I'm saying, that if you look here, it can be subtle, and it can give you the illusion that there is actually a midline, but it isn't. And certainly when you raise, you come up in the plane, you can see that the cerebral hemispheres are fused. Similarly, ventriculomegaly, although there's no official definition, it's coming online in terms of like measuring areas and things, but we can see that this is quite clearly abnormal. You can see the difference in where the choroid plexus are, and this is eventually going to emerge as schizencephaly. Spina bifida, this is probably quite difficult really in this plane, and it does require a degree of experience, but what's actually happening is the brainstem is increasing its width. Okay, so what's happening is an open neurotube defect. The spinal fluid is leaking out, and the brain's sinking back into the head, and as such, it's closely opposed. It's going to give you those classic signs in your second trimester anomalous scan, but before it gets there, a part of the process, the brainstem is going to become relatively enlarged, and the fourth ventricle and cisternomegaly are going to be squashed down. So this is the key difference, okay? So you can see. Now that's getting up to about 50 to 60% detection rate, and this is at 12 weeks. So, and this is why I was just putting the slide up again, really just to say that it's this area, the sort of mesencephalon going into the brainstem, that's the area that's flattened down. And if we look at it in a transverse section, this is easier for me. I find this much easier than the other one. Although unfortunately it's not really been peer reviewed. But this is normal, and you can see the gap really where the brainstem's there, and this is going to become the mesencephalon if you go up a little bit. And you can see how that has just been pushed right against the occiput. Okay, it's much easier really in that plane than it is in the other one, I think, where you can have quite a few different alignments. All right. I'm not talking about the posterior fossa again, that's still relatively controversial. We're just going to go on to echocardiography, and then we'll finish. So we can see fetal heart conditions are more common than Down syndrome. We've got the classic cardiac markers, ductus venosus, tricuspid regurg, anomalous RSA, and NT. They're not just about Down syndrome. Those will be linked to a higher risk of cardiac problems, okay? We can see aliasing of the outflow tracts across the valves at an early stage, which suggests a valvular problem. Doppler's easier in first trimester than it is in second trimester. And you've got to understand that these things are progressive abnormalities and may not be there. Situs and trachea are always going to be present. But again, things like congenital diaphragmatic hernia are going to take time to develop. So I think what I'd like you to think about when you're doing first trimester scanning and looking at the heart and thinking, how on earth can I see something that small? It begins with looking at the shape. Certainly when we see Down syndrome or abnormal hearts, they tend to have a more rounded shape than these things which are normal here. Okay, that's a normal pear-shaped heart as opposed to an apple one. You will get left ventricular dominance. You can see that even at 12 weeks, and it's there. Okay, the contractility is still there. And the axis, again, is important. If there's an abnormal axis, it tends to be tetralogy of Fallot that's developing if there's nothing else going on. And then we can look at the outflow and the valves here. So this is your typical V shape, which you need. And people, you know, the success rate, you can see how of looking at the heart varies between 11 and 13 weeks quite radically. And this is what I'm trying to get back at. Okay, so some of the things you can see, obviously you've got your ductus venosus there, tricuspid regurg. Beginning to see abnormalities in the ventricle there because of high levels of aliasing. And, you know, these are your outflow tracts. You can see there's a smaller aorta there. And you can just see a bit of reverse flow in the ductus here, okay? So, we can see these are some of the typical views. This is normal, all right? This is VSD. This is hyperplastic heart. And this is right-sided dominance with what later on became coarctation. So you can see how these things are going to change. All right. And again, this is a normal outflows with a smaller aortic arch here because of coarctation. Small pulmonary trunk here in tetralogy of Fallot. And this is a right-sided aortic arch down here. So you can see how these things are, even at 12 weeks, are beginning to show differences. Okay, the heart axis, as I've said, is beginning to look increasingly important. But you need to understand the limitations of the earlier scan are time. Certainly with things like megacystis and abdominal cysts and renal systems, you're not going to be able to really define them. You're going to need some degree of progression. Okay, so in summary, I think cell-free fetal DNA will still need a scan. You can see the need for that around about 12 weeks in terms of defining 60% of abnormalities. The a priori risk and combination of scan risks are really going to be highly influential in what a high-risk cell-free fetal DNA result means. Readers have a higher incidence of problems, and I would encourage you to develop a first trimester workflow to include transvaginal scanning. Okay, and just because we've got cell-free fetal DNA doesn't mean it's worth forgetting about doing DV, looking for tricuspid regurg, and nuchal translucency. All right, thank you very much. Okay. Taking questions?
Thank you, sir.
Okay.
There is an announcement. Kindly excuse us for 2 minutes because we have a small technical error in correcting our presentation projecting on the screen. So our next talk will follow soon. Please.
I wasn't quite sure of the format for questions, whether or not it's going to be at the end, but seeing as we've got a bit of time, please, would anybody like to add anything or ask me a question?
Please write down your query so that we can hand it over for the questionnaire session. The volunteers are here.
Okay, so I mean, what cell-free fetal DNA is doing is changing the landscape of testing for us, and certainly next year from 2018, it's going to change the way that the UK nationally tests for Down syndrome. What will happen is that high-risk results from combined nuchal translucency, patients will be offered cell-free fetal DNA on the National Health Service, and obviously that's going to change how we work. I think the key thing for us at the moment as fetal medicine consultants is that our rates of invasive procedures is actually plummeting, and that's causing issues in terms of training new people to do them, and obviously the existing staff retaining their skill sets. And certainly what we're finding as consultants is we're beginning to have to decide who's going to carry on doing amniocentesis and who's going to specialize in a different area, really. So it is changing our working patterns. In terms of the ethics, obviously you're going to be able to define the fetal sex now from 10 weeks. And that is, you know, understand, I think we previously when we were testing for things, it was who's driving the bus, you know, who's actually deciding what things we're testing for now in terms of microdeletions, in terms of sex chromosomal abnormalities. You know, obviously previously we'd had ethical discussions about the rights and wrongs of this sort of stuff, and now what we're finding is that's being superseded really by consumerism. So it's challenging our practice in lots of different ways, really. But I think the most important thing is that it's presenting patients with an increased range of choices. It's definitely empowering them. And I think what we're finding is really that the cost of it, the cost of doing this has come down from something like £700, £800 to now something like £275. So, and that's going to continue to fall, I think, as an increasing number of providers enter the market. So, okay.
Morning, and I'd like to thank Dr. Kaneshwaran for the kind invitation to join your meeting, and the Trivandrum ONG Obs and Gynae Society for funding my trip, and to Dr. Cunningham for taking the brunt of the technical difficulties in the first lecture. And I'm particularly grateful for being given the opportunity to talk about one of the main enthusiasms of my career, which is how to use oxytocin in labour safely. People are often unaware that we've known about oxytocin for a long time. Sir Henry Dale, a very famous physiologist at the end of the Victorian era, studied lots of different endocrine extracts and found that when he injected the posterior pituitary extract, it made the uterus contract. And it was only 3 years later that this was already in clinical practice. Sir William Blair Bell, one of the founders of the Royal College of ONG in the UK, used it to control postpartum hemorrhage. Now, I worked for many years at St Mary's Hospital in London, and that was where Alec Bourne worked, one of my famous predecessors. And as early as the 1920s, he was studying the use of the pituitary extract to stimulate the uterus during labor using the apparatus that you see here. And in this famous paper from 1927, he showed the dramatic effect of giving oxytocin and producing gross uterine hyperstimulation. And in conjunction with many of the subsequent papers, he never mentioned what happened to any of the babies in these labors. But I think you can see that the risk of hyperstimulation of the uterus was very evident a long, long time ago. And indeed, he said that although he thought that the use of this extract would be valuable in midwifery, that it could cause major problems, such as lacerating the cervix, rupture of the uterus, to the extent that many of his colleagues thought that we should consider the use of oxytocin before delivery of the baby as potentially highly dangerous. And I think we still need to have that awareness now, because as you'll see in my lecture tomorrow, it's causing us huge medico-legal problems. Now, Alec Bourne was giving oxytocin as an extract subcutaneously by injection. And it was in the 1940s that at University College Hospital, Theobald found that if you infused it intravenously in very small amounts, you got a more controllable effect, because the half-life in the blood of oxytocin is only about 3 to 5 minutes. So when you turn it off, the effect wears off much more quickly than with the subcutaneous injection. And a famous South American worker called Roberto Caldera Barcia did some amazing work, and I don't have time because I'm limited to 20 minutes to explain to you how he did these amazing experiments, but he gave infusions of oxytocin throughout pregnancy. And he found that in early pregnancy, at around 20 weeks, you needed as much as 128 milliunits a minute to make the uterus contract. But already by 40 weeks, the average effect was produced by only 4 to 8 milliunits, a very, very small dose. And in labor, as much as 1 milliunit a minute would often produce a marked response. And this we now know is because of the increase in the frequency and density of oxytocin receptors in the uterus. So the basic message is, the further on in pregnancy you are, the less oxytocin you need to give, and the easier it is to make a hyperstimulation. Now, in my opinion, the biggest deviation of our path from using this oxytocin correctly was brought about at the National Maternity Hospital in the 1960s. And this was when they suddenly had a leak in their roof, and delivering 7,000 women a year, they had to go down to only 5 labor rooms. So Kieran O'Driscoll, who was the master of the National Maternity at the time, introduced what he called the active management of labor. And initially, this was to get the women through labor very quickly so that they could get more women through the same number of labor rooms. And he subsequently claimed that this kept the caesarean section rate low, and this was an advantage. In fact, the caesarean section rate at the National Maternity Hospital today is very similar to the caesarean section rates everywhere else, for example, in the United Kingdom. But he initially introduced this idea that you could give lots and lots of oxytocin, and the only time you needed to stop it was when the baby became distressed. And this is rather like giving a drug until you make the patient very ill and then reducing the dose rather than trying to get the correct dose from the beginning. And this was a paper published in the British Medical Journal in 1969. And by 1973, he was advocating using very high rates of oxytocin. This, as you can see, was equivalent to up to 40 milliunits a minute, which, as Calderaro-Barcia had already predicted, was going to cause gross uterine hyperstimulation in many patients. And in fact, they were so enthusiastic that they gave oxytocin to more than half of all the women in first labors. These are otherwise normal labors, and they were stimulating. And that was because he took 1 centimeter an hour, cervical dilatation, as the cutoff, which of course is the average. So if you take the average rate, then that would be like taking an average blood pressure and giving the top half of the population antihypertensives, which I always thought was a bad idea. Now, this is actually me in 1978, because I felt that giving these gross amounts of oxytocin was a bad idea, and that we should adopt a physiological approach, as Theobald had suggested, and as is used in just about every other medication. In other words, you try and find the optimum dose and you give that. You don't just give a maximum dose and then back off when the patient has side effects. And I don't have time to go through the detail, but basically we gave a low dose of oxytocin if the contractions were weak, and as the contractions improved, we actually were able to reduce the dosage again. Simplest way of explaining this is to just give you a couple of examples. This was the system we produced. It was a closed-loop feedback system which measured the uterine activity with intrauterine pressure catheter and then controlled the oxytocin accordingly. And if we look at this example, initially, when the catheter was put in, the uterine activity at the top, measured in kilopascal seconds, or you could measure it in Montevideo units, doesn't matter how you measure it, was low. And so the oxytocin was started, 2, 4, 6, 8, 10, 12 milliunits a minute, and then when the uterine activity seemed to steady off, what we call the stable phase, we found that you could reduce the dose, and this woman only needed 6 milliunits a minute and then delivered just about 4 hours after the beginning of the labor. And we also had the ability to respond to increasing uterine activity. So here, when the labor was started by rupturing the membranes, there was initially some quite reasonable contractions, that's between the solid lines, and then as the contractions fell away, the dose started. So it went 2, 4, 6, 8, and then the uterine activity was increasing, hit the upper limit of normal. So the dose was reduced by half. And then it went up again, so we reduced it by half, and so you can see by the end of the labor, this woman is in good labor with no problems, strong uterine contractions, and no oxytocin. And this is what I would regard as the optimum way of giving oxytocin so it's properly controlled. Unfortunately, I didn't have Professor O'Driscoll's persuasive powers. The concept of the active management labor is very seductive. It's very simple, it's very easy to use, and it swept the world in many ways, much to the detriment of women and their babies, in my opinion. Unfortunately, trying to get people to do the control of labor scientifically seemed to be much more difficult to persuade people about. However, having looked at induction of labor, then we moved on to look at augmentation of labor. And you remember that O'Driscoll was stimulating more than half of women in normal labor. And we looked at this in a prospective randomized controlled trial, which in the days of the 1980s was quite unusual. And you can see here that the caesarean section rates were similar using the controlled approach compared with the high dose. But even in the control group, there was no oxytocin given at all. 55% of women delivered vaginally without needing oxytocin at all, even though they were initially in slow labor. But the most striking thing, which confirmed our concerns, was that in the high-dose group, a third of women experienced gross uterine hyperstimulation, usually with an effect on the fetal heart rate. And indeed, I was lucky enough to be what's called the opponent in Sweden, what we would call the examiner for the higher degree, the PhD of Sophie Berglund in Sweden. And she produced this paper, which was published just about 9 years ago. And she was actually looking at a large number of cases of suspected medical malpractice in Sweden. They have a state compensation system. And they found that about 40% of babies, there was evidence of malpractice or poor supervision of the labor. And as you'll see in my subsequent lectures, this is a very consistent finding. And overlooking the signs on the heart rate tracing of asphyxia was the most common, but equally important. In 2/3 of cases or more, there was evidence of excessive use of oxytocin. And this confirmed my view that this is potentially a dangerous drug. And as you'll see in my talk tomorrow, if you're still here, hopefully you will be, this is driving a massive problem of litigation. We seem to find it very difficult to persuade people to use oxytocin correctly and safely. And just to give you a few examples of some of the cases that have been reported in the media. This is going back again about 8 or 9 years, but this case is absolutely typical. This lady, as you can see, sadly lost her baby. Baby was stillborn, and she was the case was investigated by the Ombudsman in England, who said it was indefensible the way her labor had been managed. The drug used to speed the labor should have been stopped when the CTG showed signs that the baby was deprived of oxygen. In other words, the heart rate pattern had become abnormal. Now, in my opinion, and this is the evidence I give in cases that I represent, either the defense or the plaintiff in court, is that if the heart rate pattern is not normal and you're giving oxytocin, you should stop giving it immediately, because in many cases it's too much oxytocin which is the cause of the problem. Not to stop it is, in my book, immediately indefensible, because all the guidelines of which I'm aware say you must stop if the CTG becomes abnormal. And yet it's extraordinary how often people don't do that. And in fact, this is a common reaction. You get this perverse response from the junior doctors or inexperienced obstetricians who say, I'm worried about the baby, the heart rate is abnormal, so let's get the baby out even quicker. And they turn up the very thing which is causing the problem in the first place. It's extraordinary, but it's one of these peculiar human mistakes that occurs over and over again that we need to become aware of. Now, the NHS Litigation Authority, which just had its name changed. The government became very worried that the NHS Litigation Authority suggested that this was a standard thing, that you have litigation. So they've changed it to NHS Resolution. But changing the name doesn't change the problem, as you'll see tomorrow. In 2012, they published an analysis of their maternity claims over a period of 10 years. And they published a number of case studies, and this was number 2. A woman who was post-dates, this is a common scenario, the fetal heart rate became abnormal, the birth attendants got confused, and because the contractions were so frequent, they thought that the decelerations were the baseline, and the baseline was accelerations. And when you have frequent contractions, it's a very, very common mistake that people make. And so they prescribed syntocinon to speed up the delivery. And you'll see here, the midwife increased the dose of syntocinon several times despite the abnormality. And this is the bizarre thing. I was involved in a case earlier this year in the coroner's court where the entire hospital staff attending the woman have been referred to the General Medical Council. They've been investigated by the police for manslaughter, because people do not understand how when the CTG becomes abnormal, you actually keep increasing the oxytocin, making it worse and worse. Is this acceptable in any way? I would argue that it's not. And this is a case in which I was actually an expert in favor, arguing for the plaintiff, because I thought this was such a terrible case. And it's absolutely typical. Older mother, she's overdue, people are not inducing labor early enough. The national guidelines say you induce from 41 weeks. People are consistently being left to 42 weeks or later against the national guidelines. She was then allowed to be in labor for a very long time. She was given epidurals, and it's all a lot of stress. And there was one thing she barely noted. The junior doctor kept being called because the midwives were worried about the heart rate pattern. And her response every time was to turn up the oxytocin, and she did that 5 separate times. Every time she was called, she just said increase the oxytocin to get the baby out quicker. It seems impossible to believe, but I promise you that this is such a common problem. So is this of value? Well, let's look at the Cochrane meta-analyses. There's one here from 2013, and they analyzed 14 trials of over 8,000 women. And if they gave early oxytocin for slow labor, the cesarean section rate was 11%. But if they didn't give oxytocin at all, the cesarean section rate was only 12.3%. This was, in fact, not a significant difference. So at the best, you can reduce the cesarean section rate by 1 or 2%. Considering the risk, I don't think it's worth it. This was not a statistically significant result. The labor was a little shorter by 1.3 hours. In this study, just an hour and a quarter or so. In most studies, it's less than 2 hours shorter. So the benefit is extremely small. Here's another one, also in 2013, another Cochrane review done by Bug. They looked at some different trials, 1,200 women, and they found no discernible difference in the number of cesarean sections. The reduction in the duration of labor was only 2 hours. So that's where we say between 1 and 2 hours. And they said the dilemma is that a drug that's been used for over 40 years, actually a lot longer than that, if you actually read the literature, has not been proven to be effective in improving the outcome when you're using it to augment labor. This seems to be a very difficult conclusion for people to accept. They're wedded to the use of oxytocin. What do the national guidelines say? Well, for over 10 years, they said that if the woman is in slow labor and you want to put up to oxytocin, what you must tell her is that you may shorten the labor by 1 or 2 hours, but it will not change the likelihood of her needing a cesarean section or not. This was reviewed in 2014, slightly different words, but exactly the same message. Will bring forward the time of birth, but will not influence the mode of birth, does not decrease the rate of cesarean sections. So what is the optimum regime? Well, the American College is the only major guideline that's actually recommended doses. The RCOG ones don't suggest doses. But they say, if you're going to give oxytocin at all, start at a very low dose, because the woman is in labor, and as Caldera Barcia showed more than half a century ago, she's likely to be very sensitive. So yes, I would say 1 milliunit a minute. It's a very low dose. And you give the increases very slowly, because the woman will increase the sensitivity of her uterus as labor progresses. So very often you don't need more than 1 milliunit a minute. And I would argue that the average dose that you should use should be about 4 milliunits a minute if you're going to use augmentation, and you should rarely ever need more than 12, maximum 20. But this should be exceptional, perhaps once or twice a year. Now, there's another very interesting point. You've already seen that when we did our studies, and I did this for my MD, very often the sensitivity increases and you can turn the oxytocin off. And this has now been investigated in a meta-analysis published just about 18 months ago. And what you will see here is that actually routinely turning off the oxytocin at 5 centimeters actually did succeed in getting a significant reduction in the cesarean section rate from 14% to 8%. This was statistically highly significant, as you'll see from the little diamond. And this was attributed to the fact that there were far fewer abnormal heart rate traces requiring urgent delivery of the baby if they stopped the oxytocin. So far from using oxytocin routinely, the message that we should be giving is that actually, usually the best way of getting the woman not to have a cesarean section is to turn the oxytocin off, not to start it in the first place. And indeed, I am one of the principal investigators in a trial that's currently going on in Denmark in 4 hospitals, and we're hoping very shortly to start in another 4 hospitals in the Netherlands. And this is actually Sidsel Boy's trial. She's coordinating the trial, and this is of routinely discontinuing any oxytocin whether for induction or augmentation, at 5 centimeters. And the hypothesis is that that will show that there is a benefit from not using oxytocin compared with using it continuously up until delivery. If you want to read in more detail, the Obstetrician and Gynecologist, which is the Royal College's publication for continuing medical education, just last year we published this extensive review. So a lot of what I've told you is in there with all the scientific evidence. But actually, again, about 18 months ago, I became so convinced that using oxytocin was such a major medico-legal liability, I estimate it's costing the government about £500 million a year to compensate women for damage done by oxytocin to babies during labor, that I actually advocated for the first time that perhaps we should ban the use of oxytocin for augmentation as being too dangerous and of little or no benefit. So we may be coming full circle from the early days of discovering oxytocin to realize that actually it was a false promise that this was going to improve the outcome of labor, and it's actually proved counterproductive. So thank you very much for your attention. I look forward to any questions.
Thank you very much. Very good morning to all of you. At the outset, my usual thank yous to Dr. Jayakrishna and the team of Trivandrum Obs-Gyne Society for inviting me. It's always a pleasure to be here, not only to share what little I know, but to learn more from my esteemed colleagues. Wonderful 2 lectures to kickstart. Before I start my talk, I would like to ask if there is anyone in the audience who practice cord blood sampling at birth. I mean, apart from you too. I see only one hand. And yes, before I went to UK in 1997, I didn't know about this. So I spent a decade over there and I learned the value of it. And when I came back and joined Fernandez Hospital in Hyderabad, they weren't using it. And now I'm proud to say we do use it. Although we don't do universal cord blood gases, we do use for the high-risk indications, which I will enumerate. So therefore, anticipating that many wouldn't be using this tool, I kept this talk to the basic minimum just to show you a sampler how to implement this and what is the importance of this, most of which probably you already know. So the value, this has first been recognized in 1958 by James Ellis et al. It gives an indication of the preceding fetal hypoxic stress just before birth. Since then, it's become widely accepted, and the RCOG and ACOG recommends that we do this in all high-risk deliveries, but the Canadian guidelines say that it should be done routinely for all deliveries, which is not too wrong thing to do. So what is the value? The clinicians who care for these newborn infants must always be familiar with the principles and this practice before we put in place. And we are all involved in childbirth, so we all need to learn this simple technique. Now, what do we get out of doing this? We will know the answers to 2 questions: how well the oxygen supply has been maintained to the fetus, and how well the fetus has eliminated the CO2. These 2 are the basic questions that we want answers to. And as you can see in the jigsaw of the newborn assessment and management, cord blood acid-based results form a key central role. But each of it in this jigsaw do not have significant role independently, but all put together, the value is crucial. So it is objective. The beauty of this test is it is objective. There is no subjectivity in it. In other words, if 2 people did it at the same time on the same sample, they are more likely to get results more or less the same, unlike the UPGARs. UPGARs have a subjectivity attached to it. So this gives information about placental gas exchange. It gives you an immediate feedback. For example, if you've done a CTG, you reviewed a CTG before birth, you thought the changes are benign, and therefore you decided to wait. You wait with bated breath to see, did the baby cry immediately? If it cried, then your decision is right. If it didn't cry, then your decision is wrong. You could go back and improve your CTG interpretation skills immediately on the same day. So the advantages, in other words, it will help in newborn assessment, management, audit your own CTG practice, and also it is useful for medico-legal purposes, which I will enumerate in a little while. Now, we all use this term birth asphyxia quite loosely. it is extremely important to define this objectively. It is a condition of impaired blood gas exchange leading to progressive hypoxemia and hypercapnia, that is low oxygen and high CO2 in the blood with a significant metabolic acidosis. In other words, it is actually a metabolic definition for which you really need these cord blood gases. But people you often see in clinical practice using this term very loosely, especially before I make this statement, are there any pediatricians in the group? No. Sometimes we get caught out because the pediatrician has uttered something and the parents come back to us and ask us, I am told that this baby had birth asphyxia. So we need to be careful. Then if you have your cord ABGs there, you can say, very confidently, no, it is not intrapartum related. So there are indications that have been mentioned by RCOG and ACOG that we should do as a routine is in delivery or suspected fetal compromised babies, that is with CTG changes, or if a baby has come with low Apgars at birth, you can do it then and there. In severely growth restricted fetuses, abnormal CTG changes, intrapartum fever, if there is Doppler compromise, and sometimes even in multiple pregnancies. So what can happen if hypoxia occurs? The worst that can happen is death, as we have heard from the previous speaker. The Apgar scores will be less, obviously, 7 at 5 minutes. And when you do cord blood gases, you see pH less than 7, usually 7.05, and with a base deficit of -12. So these are the outcome measures that you come across. So in the management algorithm, where does cord blood gases fit? So when you're called to see a CTG, which is abnormal, you want to identify and correct any cause like increased oxytocin, for example, you correct it. And you still don't see improvement, you do a stimulation test, either scalp stimulation or a scalp pH or lactate. And if you do find borderline values or low values, you deliver within half an hour. And then you correlate this with the cord blood gases, with your Apgars, and document the whole thing. This is your medical legal protection. So this is how the algorithm flows. And everybody should know how to identify the vessels. This is a normal cord segment that we all see immediately after delivery. And we all know the umbilical vein carries the oxygenated blood to the fetus, and the arteries carry the deoxygenated blood with CO2 back to the placenta. So the concept is, if there is enough oxygen, the baby utilizes it and derives energy from the metabolism of glucose in the presence of oxygen, and then releases CO2 as an end product, which is eliminated in the form of H plus and bicarbonate, which go back to the placenta and then reform as CO2, which is transferred to the maternal blood and then gets expelled. This is how this works. In the absence of oxygen, what does the baby do? Which is very, very common, because in labor with contractions, the baby is bound to, the blood supply is bound to be interrupted with cord compression and lot of contractions. So then it goes to the plan B, that is the anaerobic metabolism. So the baby has stores of glycogen, so it utilizes that in the absence of oxygen and derives its energy, but the end product there is lactate. That leads to metabolic acidosis. So one needs to know this simple physiology before we actually implement the test. So how to identify the vessels? The vein is the bigger one. It has the oxygenated blood. So if people asked me, when I was naive immediately after my post-graduation, I was asked, if you are given a choice to sample, you have money to do only one vessel, which vessel would you do? And I was foolish enough to say the vein, because I would get the blood easily. But the vein always has oxygenated blood. A normal venous value has no significance because it's always carrying oxygenated blood. It is the arterial blood that actually depicts the fetal metabolism at birth. So it returns the blood from the fetus. So you need to ideally sample both. So you need to identify which is vein, which is artery. Very simple. I've taken this picture from K2MS training program, which we have in our Fernandez Hospital. And we have multiple user license for this program, which really trains. It's a very, very good training tool. As you can see, the two blue eyes are the arteries, which are thinner, and the big mouth, red mouth, is the vein. So it carries the oxygenated blood. So first step is identify the vessels. Then you know that there are two arteries and one vein. You clamp a segment immediately as the baby is born, because with delay, within 60 seconds, if you do not clamp the segment that you wish to sample, the pH and the metabolic changes can happen rapidly. Therefore, it will not depict the exact state of the fetus. So you clamp a 10 centimeter segment so that you can sample the arteries and vein. If you do not have time or you do not have staff to help you, you can keep this segment in the fridge for 1 hour, and when you get time, you can analyze the cord blood gases. At room temperature, you can do it within half an hour. Again, how you place the needle. There are a lot of sampling errors that can happen. Which do you think is the right way to sample? So keep your beveled edge parallel to the artery. The arteries are thinner. If you go straight, your needle tip may reach the vein, and you may get the same sample twice. So avoid sampling errors. Use it in a parallel way to the vein, to the artery, and get it. Don't go too deep so you don't puncture the vein twice. Then you feed these samples into your blood gas analyzer, and you get the values of both the artery and vein. I will tell you why is it important to sample both. If you have only one vessel, you cannot prove that you have sampled the artery. And the interesting result that we want is the arterial. So you need 2 samples, both from the vein and artery, to prove that you have got the arterial. So as I said, the arterial blood represents the condition of the fetus at birth. A single result has no way of checking whether you have got it from vein or artery. Venous definitely does give additional information. A normal venous result does not guarantee you a good fetus, a healthy fetus, does not rule out fetal acidemia. You may have a normal venous pH, but a very low arterial pH. So it is extremely important, and I will tell you again when that scenario happens. So the mean AV difference between artery and vein is on average around 0.08 pH units. An acidemia with a large AV difference may suggest an acute event. So suppose just before delivery there is a bradycardia, cord compression, or a massive abruption, whatever it is. So you find that the venous will be normal, and you find the arterial will be extremely low, cord prolapse. You will have extremely low. So a large difference suggests an acute event, whereas a small difference between the artery and vein suggests a chronic event, like a growth-restricted baby or a pre-eclamptic mother's baby. So they are compensating, and they have a lesser difference. So if you've understood this point, you would be able to answer this question. So you have case A, whose pHs are written there with base deficit, and case V, whose pHs are there. Obviously, which baby do you think has suffered an acute event? B. Case B, because it has a large difference between artery and vein, so it suffered an acute event, unlike case A, which had a long-standing event. So cord sampling can be done within 30 minutes at room temperature. If you do not have time, refrigerate the segment so that your changes don't happen within the segment, but do not leave it beyond an hour. 0.5 mils of blood is enough with the new blood gas analyzers. Micro samples are enough. But however, it's always good to fill the 2 ml syringe because you may need to repeat it. You may get sampling errors, your machine may break down, so it's always good to have the sample. And always, whenever you have a baby with cerebral palsy, the instant assumption is that it is because of intrapartum events, you've caused it. But actually, if you know the facts, about 1 in 2 children out of 1,000 will have cerebral palsy. And most are the result of either antenatal or postnatal events, and only 10 to 15% are thought to be due to intrapartum mismanagement. So, to link the cerebral hypoxia to an intrapartum hypoxic event, you need to fulfill these 4 criteria. There should be evidence of metabolic acidosis. How will you get the evidence? Only if you do the cord ABG. If you don't do, a crucial element is gone. Early onset severe or moderate neonatal encephalopathy, that is either seizures, irritable baby, or baby needing HIE changes. Cerebral palsy of spastic, quadriplegic, or dyskinetic type, and exclusion of other etiologies like trauma, infection, genetic causes, and so on. So unless all 4 are fulfilled, you can't actually link it to the intrapartum event. As I said, sampling errors must be minimum. Keep the needle parallel through the artery. Do not have difficulty in identifying. Take a look at the cord tomorrow. It is very easy to identify which is the vein, which are the arteries. The arteries are usually thinner, and it's always better to sample the artery first rather than the vein, because if you sample the vein and it collapses, and you're less likely to get arterial blood. So analyze as soon as possible, or when you get time within an hour. Avoid air bubbles. Heparinized syringes are already available. If they're not, in our low resource setting, you want to save money, they cost more than our normal syringes. So you can take a drop of heparin and draw within the syringe so it is heparinized. But if you take too much heparin, again, it will acidify. And artery and vein samples must be color coded. So in our hospital, we use a blue needle and a red needle, and they're marked. Okay? So this is how we document in our hospital the cord ABGs, and in all the above said indications, it is mandatory to do these cord samples. And if they're not done, we have a monthly audit where people are called and explained how important they are. So we document this way, both artery, and I don't know if it's visible at the back, with the base axis. And this is useful for our pediatricians. Just to give you an idea, Fernandez Hospital is a tertiary referral center. We have about 8,400 deliveries with 40% normal, and we are ashamed to show our 51% cesarean section rate. Unfortunately, there are many factors that go into it, and now we are displaying our cesarean stats on the website for people to look at, and government is going to make this mandatory to show your cesarean section rates. Out of this, last year, we have done about 9,700 odd cord ABGs. The billing bills arterial as one and venous as one. So that's why you've got double the number. So paired samples are around 4,800 out of the 8,000 deliveries that we did. So at the moment, we are not doing for elective cases or babies where there are no CTG changes, where we do not suspect any hypoxic changes. We are not doing at the moment, but ideal would be to do for all, because we don't know which baby will go to litigation in the future. So these are the average normal values for artery and pH. You can laminate and keep it in your labor ward so you know what you're dealing with. We define metabolic acidosis as pH less than 7 and base deficit of more than 12. The timing of insult matters to diagnose what condition the baby is born. Ideally, we want a baby with normal pH and normal base deficit, but gradually there is reduced oxygen supply, there is decreased pH, but initially the base deficit is still normal. That is the respiratory acidosis, where the baby can still compensate and come out in a good condition. But if you do not identify this baby at this stage, it continues, the hypoxic insult continues, then the base deficit is also increased, leading to metabolic acidosis. And then gradually, if there is an acute event, you have a difference between arterial and venous samples. And in the long time, both the samples are affected if you don't act on it. I'm not sure why it went. So to conclude, cord ABG is the most, can you go back to the slide where I was? We have done this. In combination with other information, normal paired arterial and venous blood gases can usually provide a robust defense against a suggestion that the infant had hypoxic ischemic event. So you need this proof as a backup for you. It is useful, and the future is looking at this, and we need to wake up. All of us, care providers and institutions, should consider the cost efficacy. I know we always look at cost for our patients, but it is worth it given the inaccuracies associated with electronic fetal monitoring. You need to have this as your backup defense. It is the best way as available now to document fetal acid-base status at birth. And this is another test that I took from K2MS to give you an idea whether people, we always have this test in our classes. Do you want to have a go at this? Good technique, obviously, in collecting and analyzing blood, and you need blood from both artery and vein. And awareness of the full clinical picture is important before you make a judgment. And use of venous as well as arterial values, important. Use of PCO2 and base deficit as well as pH values, useful. Understanding that cord blood gas results alone are not good predictors of neonatal outcome. It fits the jigsaw where all have an equal role, and appropriate use of reference ranges is important. Now I'll show a small video that my registrar has done just to show the audience who have never done cord ABG. So we label this way. You can either have a difference in the syringe sizes or the needle colors to know which is artery, which is vein, you write a protocol for your unit. So this is the cord sample. It is, you don't need to do that. It is, you don't need sterile technique to do this because it's done outside the body. So identify the vessels. The thinner one is the artery, and the thicker one is the vein. Now, we are not using heparinized syringes to cut the course, so a drop of heparin is taken and flushed out so that it doesn't clot before it reaches the analyzer. Too much heparin should be avoided because it can acidify. So you have plenty of time to do this, but only thing is you need to double clamp the segment and keep it. And the clamping should happen within 60 seconds to depict the picture accurately. So do not do the vein first, because in my experience it collapses and you find it harder to get the more useful arterial sample. It is very simple, easily doable, and it costs 300 rupees. So it's such a good defense for us obstetricians that we must all make an attempt to do this. In the UK, do you, if I may ask, do you do universal cord blood gases? Mr. Steer? Do you do universal cord gases in the UK now?
Yes, we do.
Universal.
Not in the UK, we do it various hospitals. We have 7,000 deliveries.
All of them, even electives.
Yeah, we have 7,000 deliveries, and we do all of them. I think
Right.
the issues we have are that babies sometimes collapse
Yes.
postnatally. Like you say, you can have several different interpretations for CTGs, and it's very difficult to actually know what's happened. I think the other thing about it is it's not just about medical legal, but obviously when it's 7.1, that's like a trigger for a risk management investigation. So it's about trying to anticipate problems and improve practice, really. In sort of rather than waiting for bad things to happen, you're sort of setting a relatively high threshold, and it's just trying to refine practice as well.
Sure.
So that's probably a key thing.
So we can improve our management. So for India, as a first step, at least for high-risk cases, it's a start. Hopefully we'll aim for the whole thing. So thank you very much.
I think I'd ask Dr. Simon, before I open up the queries, can your cell-free DNA replace the double marker used for the screening of chromosome problems?
So before I answer that, can I just clarify what you mean by double marker?
Double marker?
Yeah.
Instead of doing the double marker, can you go straight for a cell-free DNA testing around about 12 to 13 weeks? And can it be used as...
You mean the HCG and PAP-A?
Yeah.
With the NT.
NT.
Yeah. Okay. So I think one of the key things is that it will still need a scan. You know, the combination of the two's always going to be necessary. It is more accurate than doing the double marker. The double marker will give you, if it comes back high risk, will give you a positive predictive value of about 5%. So only 5% of your high-risk results will in fact have Down syndrome. The cell-free fetal DNA has a positive predictive value of 70 to 80%. So you can see there's a world of difference there, okay? Not only that, but the double marker is only going to pick up something like 70 to 80% of Down syndrome pregnancies. The sensitivity of the cell-free fetal DNA is 99%. So not only is it only more sensitive, but it's also much more specific as well. And you know, it's reducing the rate of unnecessary invasive investigations. What hasn't been studied really is how it's going to be rolled out across a whole population and the effect that's going to have. And I think that information is going to come to us in the next few years, really, as the cost has come down and it's become increasingly available. So it is going to replace those tests, but the scan's still going to be necessary.
Yeah. Next question, Dr. Philip. Stopping Pitocin at 5 centimeters. Can it be restarted anytime again, and do we have to wait for the patient to spontaneously progress? Stopping Pitocin at 5 centimeters cervical dilatation.
Yes, of course, it's always possible to restart the oxytocin if you wish. There aren't any randomized. Yeah. There are no randomized trials to say whether we should restart the oxytocin or not. I think the answer is that once you get to 5 centimeters, it's likely that the uterine activity is sufficient, because that's why the woman got to 5 centimeters. If there is subsequently very slow progress, you've got a number of options. You can either just be patient, provided everything appears to be healthy with the mother and the baby, and I think we need to rediscover patience as obstetricians. Or we need to start looking for other reasons why the progress is slow. It's not usually due to inadequate uterine activity. So it may be macrosomia, it may be a malposition, it may even be something as simple as a full bladder, which is quite common in women with epidurals. So the national guidelines in the UK now say that before restarting oxytocin in that situation, an experienced obstetrician must take a detailed reassessment of the whole history, the progress, clinical examination, and make sure that there isn't some other reason why the progress is slow. And in my experience, usually there is another reason. Restarting the oxytocin is not a simple solution to a complex problem.
And question following that, can we start oxytocin before rupture of membranes? Whether it is associated with increased risk of amniotic fluid embolism?
The answer is yes and no.
Yes and no?
There is no evidence that starting oxytocin in an appropriate manner with low doses, starting at 1 or 2 millunits, is associated with any increase in the risk of amniotic fluid embolism. That came from a few case reports 30, 40 years ago, where people were giving large doses and there was acute hyperstimulation and then the woman collapsed. In fact, if you look at cases, large case series, where oxytocin is used appropriately, there's no evidence of an increase in amniotic fluid embolism. So I would have no concern about starting, if, for example, the cervix is not very favorable and you can't get to rupture the membranes easily, we would routinely give oxytocin for 2 or 3 hours and then reattempt to rupture the membranes. And I would have no concerns about that.
To Dr. Kameshri, we have heard a lot about fetal blood sampling. How does it differ from the cord blood sampling?
Fetal blood sampling is done before delivery. If you have CTG changes, it's not pathological, so you're not sure whether you can wait safely or whether you need to intervene. Then you take a drop of blood from the baby's scalp, and previously we used to measure pH, now we are doing lactate measurements. So if the measurement is 4.8 and above, we take 4.8 as a cutoff, above which then we bail out and do a cesarean or instrumental delivery or whatever it is. But fetal blood sampling is in the intrapartum, before delivery.
But isn't it more useful than your cord blood sampling for the
Both.
babies?
You need both. You need absolutely both. You may do a fetal blood sampling, scalp sampling, and you may get a normal result, but with time, before delivery, it can deteriorate, it can change. So the cord values represent the condition at birth. The scalp lactate or pH represents the condition at the time of sampling.
Yeah, yes, sir.
Just one practical comment about the cord sampling. When we started in our unit to do it routinely, we did it on babies where there was any concern about the baby's condition because of lack of resources. But as staffing has improved, the advantage of doing it routinely is that people become more skilled. You develop the expertise. And the second practical point that I would make is that with the clamped specimen of cord, I found it quite useful to take the venous sample first and empty a vein because it made the uterine vessel more obvious because it's still one with blood in it, and secondly, it makes it a little bit less likely that you will take a venous sample by mistake. So it's just a practical point.
Dr. Simon, your comments?
I think as a habit, if you're taking a fetal blood sample, you should always really take the cord gases at birth, really, because you want to validate the two against each other.
So in Fernandez, you're validating both against each other?
Yes.
Yeah, that's good. Dr. Simon, how to differentiate omphalocele from an physiological hernia?
By waiting a couple of weeks, I think is the quick answer. Again, it's just getting used to seeing them, I think. Physiological hernia, we tend to get hung up about, but at 12 weeks, you're not really going to see it very often. And it tends to be relatively mild, and it's usually just a bubble around the, obviously at the level of the umbilicus. Omphaloceles tend to be much more profound. I think on that note as well, even the large omphaloceles that you'll see, which are almost as large as the baby's abdominal circumference, they can still be operated on. And of course, I think just in case people aren't aware of it, I'm sure you are, but obviously the larger ones tend to be just an isolated abnormality, and it's the smaller ones that tend to be associated with chromosomal problems. Yeah.
And one last question, what are the limitations of first trimester screening, anomaly screening?
So the limitations of first trimester, I tried to get these across, and thank you for the question. I think the key limitation is actually the development that's occurring. Okay, we're kind of entering a position really where the machines now are advancing to the point where we're getting better and better views, and I'm not too sure about using 3D. I think that's still in the future, but certainly what the limiting factor is becoming is really the embryology, waiting for things to develop. I think you saw my graph between 11 and 12 weeks, how the detection rates improved, and that's really because a bit more development has occurred. Okay.
So any more, thank you. Thank you very much. For any more points, Dr. Steer?
Can I ask for the privilege of asking the audience a question? Can those people who use oxytocin to augment slow labor, please put their hands up? Almost all, okay.
Almost all.
How many of you tell the women that when you start oxytocin, you're doing it to make her deliver more quickly, but it won't change the way she is delivered? How many of you tell the women that it will actually help her to avoid a cesarean section?
No.
Yeah, I'm not sure if that's...
Dr. Simon, one last question for you. Can we use power Doppler prior to 12 weeks? Doppler prior to 12 weeks of pregnancy?
Thank you for the question. I think you're trying to avoid power Doppler in the first trimester, really. Yep.
That's right.
Thank you. As a token of love and gratitude, we'd like to present the speakers with a memento. First to Dr. Simon Cunningham. Dr. Philip Steer. And Dr. Kameshwari. Thank you all speakers for the wonderful session.
Thank Dr. Jayakrishnan and his team for inviting me here. As has already been announced, I'm going to talk about early and late onset IUGR, surveillance and management. Now, this condition forms part of a placental syndrome group of abnormalities where you have preeclampsia and fetal growth restriction. Various etiological factors ultimately lead to abnormal deep placentation, which causes uteroplacental vascular insufficiency with major consequences to the fetus in terms of increased perinatal mortality and morbidity. The only treatment that we have today, once the diagnosis is made, is to deliver the fetus at an appropriate time. And this is where surveillance helps. It helps to strike the delicate balance between intrauterine death and stillbirth on one end and neonatal death at the other end. It tells us what is the time to appropriately deliver the fetus so that it does not succumb to either of these eventualities. So the three pillars that we have in the diagnosis of IUGR today are diagnosis, that is recognition of the condition, surveillance, and properly timed delivery. Now, does surveillance, trying to diagnose this and delivering on time really help? This slide will tell you all. This is a study done by Gardozzi et al., where they clearly showed the overall rate of stillbirth was about, why is it, it's not displaying, please? The overall rate of stillbirth in the general population was 4 per 1,000 live births. In the group with no fetal growth restriction, it was half this number. But with fetal growth restriction, the risk of stillbirth increased to about 16 to 17 per 1,000 live births. Merely recognizing this condition decreased the stillbirth rate to 10, and failure to recognize increased it to 20 per 1,000 live births. So this is the overall stillbirth rate. It increases to 16 if there is fetal growth restriction. Not recognizing it increases further to 20 per 1,000 live births. But the moment you recognize, it decreases to 10 per 1,000 live births. So a 50% reduction is obtained just by getting, by recognizing the condition. So recognizing the condition, diagnosing does help, because surveillance and timely delivery will follow. And it has been found that term IUGR fetuses who are under surveillance are delivered at least 10 days earlier. Now, the diagnosis of FGR traditionally depended on biometry. But it was found that there's a lot of overdiagnosis when we depend on biometry alone, and there is a percentage of growth restricted or compromised fetuses that we will not diagnose if we depend on biometry alone. This is because all SGAs are not fetal growth restricted babies, and all fetal growth restricted babies are not necessarily SGAs. There are a group of averagely grown babies which have vascular compromise. So we started adding Doppler to the biometry. We said we will use umbilical artery Doppler, and if that is abnormal or the MC is abnormal, we will call it fetal growth restriction. But that is also not thought to be enough. A group of fetuses, particularly those that develop late growth restriction, may have only an abnormal cerebroplacental ratio with umbilical artery and MCA still remaining normal, or they may have an umbilical artery abnormal or a uterine artery alone abnormal in addition to a mild growth restriction. Of course, the very small fetuses are easy to diagnose because they have such a severe growth restriction that it's easy to call them abnormal. So there is a shift in the diagnosis of SGA or a fetal growth restriction from biometry to hemodynamics, except in the very, very small fetuses. So what are the consequences of uteroplacental insufficiency? As you can see here, there is uteroplacental insufficiency causes increase in the placental bed resistance, which is manifested as increased uterine artery resistance. There is hypoxia and starvation because of decreased substrate to the fetus, and growth restriction happens. Initially, there is cerebral head sparing effect because there is cerebral vasodilatation in response to hypoxia, which causes increased flow actually in the ductus venosus and increased diastolic flow in the middle cerebral artery. As the disease worsens, more severe changes occur in the umbilical artery and the ductus venosus. As you can see here, The starting point may have been an abnormal uterine artery screening, that is a positive uterine artery screening, and then you may find that the umbilical artery resistance is high in these fetuses. Sometimes the starting event may be just an increased MCAPI or a reversal of cerebroplacental ratio. From there, as the placental insufficiency worsens, you have absent flow in the umbilical artery, absent end diastolic flow in the umbilical artery. Hypoxia worsens, and this affects the heart. There is congestive failure and cardiomegaly. So there is back pressure, deep A waves in the ductus venosus, which progresses to reverse A waves, reverse end diastolic flow, and the pre-terminal changes. Now, we all know that we do not want, these changes are divided into early changes and late changes. We know that we do not want these late changes to happen, because along with the late changes, you have changes in heart rate patterns and biophysical profile, and pre-terminal changes start pretty soon. So we would like to deliver all these fetuses at this point, before the late changes happen. But the limiting factor is gestational age and prematurity. And prematurity is not much less an evil. It causes a lot of problems in the fetus. So we need to prevent both prematurity and hypoxia and acidosis. Now, a word about umbilical artery. This is very well known, but we sometimes fail to recognize the fact that even when there is placental insufficiency sufficient to cause hypoxia and cerebral redistribution, there is a phase where the umbilical artery can continue to be normal. So until the placental bed, 50%, more than 50% of the placental bed is lost, you still have a normal umbilical artery PI. And when almost 90% of the placental bed is lost, you see absent end diastolic flow in the umbilical artery. Now, umbilical artery interpretation can be divided into non-reassuring, where the PI value is still normal, but it is increasing if you have been following these patients up, or abnormal, where it is more than 95th centile, as you can see here. Absent. When it is abnormal, you need to start monitoring these patients weekly. When there is absent end diastolic flow, if the fetus is 34 weeks, you would prefer to deliver or monitor them bi-weekly. Reverse end diastolic flow has a worse perinatal outcome. You need to look at the ductus venosus also at that time. And unless the fetus is very, very premature, these babies need to be delivered immediately. Now, when there is normal growth happening, when the fetus is normal, the umbilical artery PI is typically low. That means there's a lot of diastolic flow in the umbilical artery. And the ductus, the MCA, on the other hand, has a high resistance flow, very little diastolic flow. But when there is uteroplacental insufficiency and fetal growth restriction, you will see that the umbilical artery PI begins to increase and the MCA PI begins to decrease. That is, there's more flow, diastolic flow, because of cerebral compensation in the middle cerebral artery. Now, this is called the reversal of the cerebroplacental ratio. And you see this reversal of the cerebroplacental ratio when the fetus is still growing normally. This green box shows you the fetuses that are still in the normal growth range. And this pink box shows you the fetuses that are growth restricted. So the reversal of cerebroplacental ratio is important because when this happens, there is adverse perinatal outcome noted. So when the cerebroplacental ratio really goes down, that is when it is about less than 5th centile, you have adverse abnormal acid-base status at birth in the umbilical cord blood. You have fetal distress developing during labor, meconium-stained LICA developing during labor. There may be an increased risk of cesarean section because of fetal distress, and there's also a high risk of neurodevelopmental abnormalities at 18 months of age. So they are an abnormal group, and we need to recognize them. Now, as I told you, we have been going more towards a hemodynamic way of diagnosing, and Khalil et al. Studied the weight model and the hemodynamic model and showed us that The weight model will identify this group as SGA. This is the normal group. The hemodynamic group will recognize this green group as the SGA group. So there's a small group here, the yellow shaded group, which is average for gestational age, but it has a vascular compromise, which will not be diagnosed if you go only by weight changes. So you have two types of fetal growth restrictions, early and late. Early is severe, late is milder, and they have different pathophysiological mechanisms and clinical features. So is it important to recognize these two? Yes, because they are different. You need to realize that the severity varies, association with preeclampsia varies, the natural history varies. If you do not recognize this, you will not diagnose these two conditions separately, and the management also varies. Now, the differentiation is also important so that you understand the pathophysiology and the changes that are occurring, and in research, you compare the right things to the right things. Now, we'll go through the differences within these two groups. The early onset is mainly a management problem. We can diagnose it because the changes are very obvious, but management is a problem because of prematurity. Whereas in late onset, it is diagnosis that is a problem. It is mild and very often missed. Coming to prevalence, it is contrary to what you and I may think, early onset is much less prevalent than late onset. It accounts for 1 to 2% of all pregnancies, and here this is 3 to 5%, but if you look at FGRs, only 20 to 30% are because of early onset FGR, and 70 to 80% belong to the late onset group. Association with preeclampsia is much higher in the early onset, 50%. It is a much severe disease, and so umbilical artery Dopplers are abnormal, whereas late onset is a milder disease, and umbilical artery Dopplers are usually normal in this group of patients. Coming to fetal hypoxia, much severe in the early onset. There is systemic adaptation, and so these are the Doppler changes you will see. You will see increased umbilical artery Doppler, absent end diastolic flow, reverse end diastolic flow, very low MCAPI, and ductus venosus changes. Whereas in the late onset, you rarely see umbilical artery Doppler changes, and you never see ductus venosus changes. The diagnosis and follow-up mainly is based on recognizing the reversal of the cerebroplacental ratio. Now, coming to the natural history, because in early onset, the fetus is premature and has a good resistance to hypoxia, there is a long natural history over which changes occur, both in the Dopplers and in fetal growth and fetal biochemical profile. Whereas such a long history is not seen in late onset FGR. The fetus in the early onset is immature, but has a good tolerance to hypoxia, and that is why this long history and sequence of changes are allowed to occur. Whereas in the late onset, the fetus is mature, it has very low tolerance to hypoxia, and therefore any worsening after diagnosis, any worsening in the placental resistance or blood flow or hypoxia will cause fetal demise, and that is why you don't have a very long history. Outcome and prognosis, this condition, early onset, has high mortality and morbidity, but it has a low prevalence, whereas late onset has low mortality and morbidity, but higher prevalence. But we must remember, we fail to recognize it, and so we are surprised by the sudden deaths that occur in this group. So just to summarize, once again, early onset is less prevalent, 20 to 30% of fetal growth restrictions, higher association with preeclampsia. It is a much severe placental disease, so you have abnormal umbilical artery, which progresses to acidosis with very severe changes in the ductus venosus as well. So there's a compensated phase of hypoxia when you have only an increased umbilical PI, increased MCA, and reversal of cerebroplacental, decreased MCA and reversal of cerebroplacental ratio. This goes on to a decompensated phase when there is absent end diastolic flow in the umbilical artery, increased PI in the ductus venosus, not yet abnormal. You just have deep A waves, not absent A waves. Now, these changes can go on for several weeks. However, once acidosis develops, the change from decompensation to acidosis can take as little as 7 to 10 days, and this is recognized by, acidosis is recognized by umbilical artery showing reverse end diastolic flow, ductus venosus showing absent and reverse end diastolic flow, CTG showing decreased short-term variability and abnormal low biophysical profile. Now, from here to severe death and injury can be just a matter of hours to days. So this is the history that we are talking about, and because the sequence of events occur, we say there is a long natural history to this condition, starting from abnormal uterine artery Dopplers to reversal of cerebroplacental ratio, abnormal umbilical and MCA Dopplers, which then goes on to abnormal ductus venosus changes. The late changes are associated with CTG changes and biophysical profile, abnormal biophysical profile. So these sequence of events have a temporal relationship. They are rather predictable, but when preeclampsia occurs, this predictability can be lost because it makes the disease more severe, and sudden acceleration of hypoxia and worsening of fetal condition can occur. So you can predict it as long as there's no preeclampsia. Once preeclampsia occurs, the condition can become much, much severe. So this is the condition where you need to do this true balancing act, deliver the baby when it is not too bad, but still avoid prematurity. Now this is a very good chart. It is included in the souvenir that you have. This shows us why we need to wait and when we need to deliver. At 24 to 26 weeks, it's better not to deliver the fetus because the mortality rate is more than 50%. Between 26 to 28 weeks, you decide depending upon the parental wishes and the ability of your neonatal ICU to look after these babies. Now, you are looking at neonatal survival at this stage, and every day in utero will give you a 2% advantage on survival, and that is why you must try to wait as long as possible. So, and it is an important point to note here is that the fetal deterioration has no statistical impact on this group of fetuses because they are premature. If you deliver them too early, prematurity is going to kill them. Coming to the next group is 28 to 32 weeks. You deliver them when your main aim is to decrease perinatal morbidity, so you can wait till there is absent A waves in the ductus venosus, but not beyond that. 32 to 34 weeks, you wait only to administer steroids and deliver them if you have reverse end diastolic flow in the umbilical artery. 34 weeks is a good time to deliver most fetuses when they are compromised, and you wait till 38 weeks if possible with close monitoring, because the longer you wait, the lesser will be the ICU stay. So you're looking at the NICU stay and decreasing it and decreasing morbidity as far as possible. After 38 weeks, of course, there's no point waiting. Now, the stage-based approach of management of IUGR, this is a very useful chart. This also is included in your souvenir. This chart tells you what to do when you find these changes, and it divides the IUGR into 3 groups. The severely small but mild placental insufficiency, severe placental insufficiency, low suspicion of acidosis, and high suspicion of acidosis. In each stages, the changes are mentioned, how you monitor them, and when you should deliver. So in the first group, you have very mild changes, the early changes of fetal growth restriction. When you find that, you monitor these babies weekly and deliver them at 37 weeks. Induction of labor is acceptable. When there is severe placental insufficiency, you have absent end diastolic flow, you still do not have, you only have increased PI in the umbilical, you have got deep A waves in the ductus venosus, but you do not have ductus venosus above the 95th centile. These need biweekly monitoring and delivery at 34 weeks. Once reverse end diastolic flow develops or ductus venosus becomes abnormal above the 95th centile PI, you need to monitor them every other day and deliver as soon as they are 30 weeks, or if they are already 30 weeks, immediately. The high suspicion group, of course, you need to be careful about the gestational age and counsel the parents properly before you take an action. Now, in the very late changes occurring early, that is between 30 and 32 weeks, the problem is which parameter to use to deliver the fetus. The Truffle study looked at this. They divided the fetuses into 3 groups. That is the CTG group, the early ductus changes, and the late ductus changes. So they were delivered, this one group was delivered when the CTG became abnormal, the other group when the ductus venosus became more than 95th centile, and the last group when there was absent A waves. And they found that waiting for this absent A waves was good enough, and it did not increase. All these 3 groups were okay. You could use any of these cutoffs, and you had a good neonatal survival with normal neurodevelopmental outcome. However, at 2 years, there were more babies alive with normal neurodevelopmental outcome in the last group, and that is why they concluded that it would be okay to wait till absent A waves so that we buy time and at the same time do not have a severe compromise. Coming to late onset, it is a milder disease. 70 to 80% of FGRs fall into this category, but we always fail to diagnose this condition because umbilical artery Dopplers are normal, no ductus venosus changes. We have to depend on an abnormal cerebroplacental ratio. Only 25% of these fetuses will have an abnormal MCA Doppler, that is MCA below the 95th centile. So it is mild disease. Then why is it a problem? It is a problem because FGR accounts for almost 50% of all stillbirths, and most of these term stillbirths occur in average for gestational age fetuses. Over the past several years, the stillbirth rate from averagely grown fetuses has actually increased from 55% to 77%, which goes to show that all our monitoring has helped the small fetus, but not the averagely grown fetus, which is compromised. So for every stillbirth that occurs, we must remember that there are some that have that are going to be appearing normal but have neurodevelopmental morbidity. Now, so we need to recognize these. They have an increased, the late onset have an increased perinatal morbidity, that is intrapartum problems can happen. They can deteriorate just before onset of labor, and they have the problem of neonatal acidosis. Now, what is the cutoff between early and late? 32 to 34 weeks at diagnosis and less than 37 weeks at delivery is the cutoff. But in addition to 32 weeks, which is an arbitrary cutoff, looking at the umbilical artery in these growth-restricted fetuses, mildly growth-restricted fetuses, tells you whether it is early or late. If it's a normal umbilical artery, this is a late onset FGR. This study just looked at why umbilical artery is a better predictor of late onset than just 32 weeks. I'll skip this for want of time. Now, how do you diagnose late onset? You see a very small fetus after 32 weeks. You have abnormal CP ratio. You may have an abnormal umbilical, you can have an abnormal MCA PI value, or the uterine artery Dopplers may be abnormal, above 95th centile. And this is the group that needs to be monitored. This is the cascade of events that is proposed by Figueras et al. Now, low CPR has various disadvantages. Even in AGA, it increases the risk of abnormal cord blood pH at birth. When low CPR is associated with SGA, it increases the risk of abnormal neurodevelopment. So obviously, they are an abnormal group. It has been found that when you have low CPR and low MCA PI values, your risk of intrapartum deterioration and cesarean section due to intrapartum deterioration increases, both in term SGA as well as in the low risk population. So detection is very, very important. How would you detect? You would have to probably do surveillance at 32 to 34 weeks. And the first section of the stage-based monitoring will work in this group, just as I mentioned earlier. You need to deliver them at 37 weeks. And the question is, should we deliver them at 37 weeks or can we wait? Now, if you deliver them at 37 weeks, you're delivering them earlier, but there's no change as far as cesarean section or adverse perinatal outcome goes. But delaying the delivery to 38 weeks will decrease the NICU admissions. So for that reason, it may be wise to monitor these fetuses till 38 weeks carefully and deliver them at 38 weeks. A corollary would be, it would be prudent to probably check all inductions by ultrasound to look for growth restriction and check for any abnormality in Dopplers, so that you are more alert as to whether you need to do you may need to do a cesarean section, whether this baby is going to have a compromise or not. Thank you very much.
Just moving swiftly on, I think this is going to be an interesting talk, I think, because I'm changing hats. I've recently completed an MSc in Healthcare Leadership and Management. The dissertation for that was engaging junior colleagues in clinical governance. And so this is very much a talk not about syntocinon, not about managing labour or looking at CTGs, but really about what goes wrong with teams in terms of a systems analysis. I'm hoping that it'll translate across, and there'll be a few points you can take, really, about how teams work. Okay, so this is me at 15,000 feet, looking very uncomfortable. And I think one of the things that this taught me about was how systems work. Okay, so you're driving up to do the skydive, and they've got a big sign on the end, you know, saying 200,000 jumps and no accidents, and you're thinking, is this the day? You know, are we going to stretch that statistic rubber band today? And what was interesting was that as it's a very orchestrated process, very formulaic. You know, there's no deviation. There's a school that are learning to parachute, and they'll catch a lift on the plane. And what was really interesting to me was that as we were about to take off, there was one of these students that came rushing onto the runway, you know, just putting all his stuff together. You know, he'd had about 10 to 15 minutes to get ready, but just left it to the last minute. And the lead for the plane just said, no, he's not coming, not coming. You know, and he just had absolute control over what was going on. You know, just recognized this guy's big risk for not putting his kit together properly, big risk for, you know, one of the buckles not done correctly, and just said he's going to have to wait for the next one. And that's great. You know, you've got such a controlled environment. That's why they've been doing it for 10 years, 200,000 jumps, and no problems. Whereas we take everybody, you know, whatever size, whatever gestation, whatever situation. We've got a myriad of environments, of people, of different clinical problems to sort out. And that's what tests our processes and our adaptability in those processes. And this is, you know, this translates into modern life, really. So if you look in the embrace, you can see it coming through in all the reports for maternal mortalities, particularly leadership and team working. To err is human. We know there's a 10 to 15% chance of an adverse event, really, in terms of when patients are admitted. And it's not just medicine. You know, medicine is incredibly complex, but think about other complex things like Challenger, like Chernobyl, to Bhopal. Okay, all those things have had human factors involvement. Okay, so this is going to be a talk about without CTGs. Okay. 10% of acute admissions have an adverse event. And my challenges to you are asking yourself these questions. How well do you lead? What happens when values compete? Because that's the key thing, is when your values are competing, when you've got 3 or 4 things to do, how do you choose the right thing to do? How close is your training to reality? How do you investigate? Do the people working with you have a voice? And how do you make changes? And let's just start with an easy thing. What does everybody see looking through? What does everybody see past the window? Can you tell me? Please, with the microphone. Do you see the tree? You do see the tree. That's great. What don't you see? You don't see the glass in the window. The glass in the window is your assumptions. Okay? You see through your assumptions when you're analyzing situations. They don't register in your thinking. All right? So that's what we're up against, really, when you're trying to take information in, okay? Okay, so I lied. We are going to look about a few CTGs, okay? This is one case, okay, so and the reason I'm bringing this is an antenatal case, nulliparous lady, decreased growth below the 10th, well below the 10th centile, 33 weeks, attended antenatal with decreased fetal movements, ended up going to labour ward, and there were no contractions. She wasn't in labour. But, I mean, what do people think of the CTG? Okay, so you can see this deceleration here, relatively stable, a bit flat. I think, obviously, we carry on. It's still like that. And I've gone back to the start there. So, and you've got another dip here. So what's interesting is this lady was on patient was on a CTG for 3.5 hours. It was attended antenatally with decreased growth movements, and nobody wanted to make a decision. The decision they eventually made was that she was discharged to come back for a scan in a week. And unfortunately, when she came back, had a stillbirth. So there are a couple of things that happened in that situation that probably didn't really ring true. One of them was, we have consultant ward rounds. We have consultant presence ward rounds, okay? This was a 5 o'clock ward round. Lady came in at 1:30. 5 o'clock ward round, decided enough's enough going on. There was no consultant presence on that ward round, and there should have been, okay? One person made the decision, but there were 4 people in the room, all of whom, when they saw the CTG afterwards, said, of course, that's an appalling CTG, or, you know, it's not a normal CTG. We should have actually either repeated it or delivered. The other thing was that we booked the ultrasound scan for the 27th of December. The 27th of December last year was a bank holiday, and that went by everybody. So the patient came to the hospital, but the ultrasound department was shut, so there was no ultrasound scan. So you can see it's kind of a team failure there on several different fronts. One is that, and we use this case now in our training to escalate the need that, okay, you've got a team lead in the room, but you've all got a voice. You know, if none of you are going to respond to a CTG that's abnormal, you're all taking responsibility for that. And I think you know, these are kind of salient lessons for us. So the problem is that, you know, obviously with 700,000 births per year, 10% of acute admissions will have an adverse event. And we forget that when we're actually thinking about CTGs. If anything, it's probably going to be more. If we have 174 cases of cerebral palsy per year and 158 perinatal deaths, I think Professor Steer's estimate earlier on was probably relatively conservative, really, because we're now seeing £1 billion per year set aside for obstetric medical legal claims. Okay. And I think what we're sort of moving on to now is kind of drawing at straws in some respects, because we're actually trying to see if computers are better at fixing the problem than us. And Greg, the problem is the care model is flawed, and we've got a single point of failure, what we've talked about. So rather than reorganizing how we deliver care, we're trying to get a computer sorted out. CTG interpretation is hard, difficult. I respect that. There is no getting away from that. I think the length of time required to make a decision is very interesting, in that we make decisions on moderately abnormal CTGs faster than we do on severely abnormal CTGs. So if it's severely abnormal, it goes on a lot longer than if it's just a little bit wrong. And I think, you know, again, what I agree with Professor Steer is that we are very much obsessed with pattern matching, following guidance. We're not actually individualizing care, not actually thinking about the situation and matching the CTG to that situation as well. You know, what is this a post-stage pregnancy? Have there been any issues? What is the level of risk? So there have been two trials looking at CTG monitoring now. You might see me in the top one in a former life. So, and what was interesting is that neither showed a benefit to computerized analysis of CTGs. The other interesting finding was that in both trials we had a better than expected outcome for the control group. And that's kind of explained away the benefit of doing the computerized analysis. So what is it that actually doing the computerized CTG trial raises everybody's game on the other patients who don't have the computerized analysis? And what is it that's changing that value system, you know? And that's what I'm interested in, really. So if we come back to this, there's something in these things here that by setting up a computerized CTG trial actually improved the outcomes for the control group who didn't receive the intervention. One of the things about Berwick, who's a recognized, worldwide recognized expert on healthcare, is he sees healthcare as a system, and that every system is perfectly designed to produce the outcome that you see. Okay, so, and it looks complicated until you begin to bring it down. And I think one of the things about this system is it relies heavily on trust. Okay, it relies trust to recognize, define values, and to understand. And the level of the trust in the organization is going to be is going to define how well you respond to failure and how well you're able to fix problems. Okay, and this is where it comes to living the values. You know, we've got detailed guidance, we've got SOPs for everything. Nothing should get by us, and we should see everything. But, you know, weird things happen. So Hillary Clinton was the best prepared presidential candidate in history, probably the best funded as well. But her values didn't really connect the American people. I think the feeling is that they show very much as part of the establishment and really more of the same when people wanted something different. And that's what we're trying to get at. The guidance, the SOPs, they're not going to change people's thinking or the connection they have with the service or the patients. You need to get to that level to actually make changes. When you're investigating risk management, one of the key things is how you make people feel. So we have this great system in the UK which will, begins with kind of ritual crucifixion of the team. We then have an inquisitorial sort of atmosphere where we're investigating. We isolate people. And the investigations tend to drag on for a long time, and everybody's tarred with the same brush. It's very difficult to foster trust in that environment. I think, moving back to this thing of healthcare as a system, it promotes a no-blame culture, really, an understanding of why things are happening, what people's values actually are, how well your organization is connected, how well you're leading people. So if we think about living the values, we think about things like hierarchies, cultures, role models, and actions, and all of these things. It doesn't matter what's on the wall, what the hospital says it believes. These are the things that define what the hospital's values are. Okay? These are the messages you send to your team every day. This is the team I'm so proud to be part of here on Delivery Suite. This is an interesting book here, Patients Come Second. And I really like this because it kind of catches a lot of things, and I think primarily is that you have to connect with your staff, your team. If you want exemplary results, exceptional results, you have to build exceptional teams to deliver them. Okay, so case 2. So this is, again, another antenatal one. So 38 weeks, induction of labor, however, she never got to the induction. She attended the induction suite. Background history of gestational diabetes, which is why she was being induced at 38 weeks, para 1. No antenatal difficulties, no risk factors, just came up, had a flat trace, and this is what happened, really. So the time here is kind of 1740. It had been already 2 hours. We had a relatively flat trace. And again, sort of seen on consultant ward round, we're just going to carry on a bit longer. Beginning to niggle, not quite sure. A bit flat, not very good quality. Beginning to wobble a bit, 1840. And then, the variation's gone 1900. So eventually, we sort of called that at about 8 o'clock. And you can see we've got a whole team involved there, and yet it still took us another hour, really, to respond to what was going on. I find that really curious, and I think it comes back to this thing that having consultants on labour ward isn't the answer in some respects. It's about changing the way we work. It's very good, getting to the bottom of it, it's really tricky. Doing a root cause analysis isn't going to help you if you can't work out that the violinist, the second violinist, is missing the third paragraph of the fourth passage, okay? it's great with an orchestra because if somebody's playing out of tune or out of time, you can immediately spot it. On a delivery suite where you've got your orchestra consists of several different tiers of staff and different variations, actually working out who's playing out of tune, who's not in time, can be very difficult. Understanding why that's happening can even be even more difficult. So we come to some data, okay? So key outcomes have been, so 2015, we had 13 babies out of 7,000 deliveries that required cooling and 2 neonatal deaths post-delivery. I took over at the end of 2014. 2016, that was down to 9, and 2017 to date, we've had 3. 2 of those have been antenatal events, people that walked in the door, and one of them was an intrapartum lady who was not our patient, who attended as an emergency after going to 45 weeks with a previous cesarean section and wanted to rebirth. So, living the values, okay, when we took over, we decided all of these therapeutic cases were going to have root cause analysis. The 2 deaths had external reviews. The junior colleagues were going to lead those RCAs. There was a lot of resistance to that because it wasn't just senior junior colleagues, it was junior colleagues from all tiers. So if they'd just become a registrar, they were going to do an RCA. And we were having conversations like, they can't even tie the shoelaces yet, but you want them to do an RCA. And I think the thing is, we wanted to get that cognizance of what goes on in care, to understand how things happened, to understand those little events, really, because their shift on labour ward lasts 4 hours, 8 at the most. It's very difficult for them to actually see what goes on after that time. We wanted to bring the consultants in, rather than keep risks at arm's length as somebody else's problem. And we also wanted to build a culture where we give good feedback regularly, really. So, as part of the dissertation, these are some of the insights that we actually gained when we interviewed junior staff about their experiential learning from leading investigations. They felt it improved the documentation. They thought through decisions better. They reviewed the patients on time, because they were seeing in the notes, I will come back and review the patient in half an hour. And they saw that colleague hadn't done it. And what happened after that? They improved their handwriting, or they actually wrote down. There's an amazing conversation where we had, one of them came up to me and asked, I can't understand why they've done a cesarean section. They haven't documented the reason for delivery. And I just said, welcome to my world. It was quite interesting. There's a real parent-child thing going on about, so this is what you're faced with. They began to understand how information becomes narrower as things get busier and more assumptions get made. They began to understand their role as clinical leaders, really, in greasing the wheels and preventing things from stalling, not just making the decision earlier, but actually responding earlier so that things actually happen faster. We haven't got time for this case. I think one of the things about this is that you need to know where you are. You need to know where you are. And it's very difficult to do that. I think this is a document which is invaluable. It's designed for acute organizations. It's a Myers-Briggs test, basically, of what your organization's safety culture is. So you pick and choose. You've got all these different dimensions down here, and A is pathological and E is generative, and you'll be somewhere in between them. And basically, you just need to have a discussion with the staff about where you think you are. So let's think about these things. We've got pathological here, reactive here, bureaucratic, proactive, and generative. Does anybody recognize any of these people? No? Yes? Okay. Apparently, this lady's got a book that is able to solve every problem ever. Is that right? Need that. Okay. So pathological, so this is just taking your organization commitment to improving care. Pathological will just give you a resume, really, of things that would characterize. So no resources are investigated in identifying problems. If any audit occurs, it lacks structure. Poor quality care is tolerated. And you go all the way through to generative, where you've got a culture of continuous improvement is embedded within the organization. Now, all of these things are not going to be pin sharp, they're not going to agree, but what they do is they start the conversation with your team and the leadership, and actually understanding where you are and where you need to be, and giving you a format for how you can get there, really. Okay. So these were our results. can see. So this is what the trainees scored as. They felt we were bureaucratic in terms of commitment to continuous improvement. We were proactive in our approach to safety. In terms of system errors and individual responsibility, we were proactive. And so you can see that it's actually pretty good, really. In terms of the culture, we did qualitative interviews with them. And this is the coding analysis. I don't know if you're familiar with qualitative studies, because we seem to be obsessed with quantitative ones. But I think the things that came through was the need for the culture to be authentic, the need for the values displayed you couldn't have favorites, you couldn't have something being wrong one day and something being wrong the next. They wanted that kind of positive climate that was consistent. These are some of the direct quotes, okay? So these are from the trainees, and we asked them what they liked about the risk management culture, or didn't like, and then they also talked about me as well. Don't really talk about me, but I mean, the top ones, these are junior colleagues, okay, who feel that they can change things. The confidence wasn't there. We're building up their confidence. They feel it's a safe and friendly place to work, and that it's more dynamic. You cannot buy feedback like this. And I come back to Berwick's thoughts really on system care, quality of care being a system property. That is what greases the wheels and makes things happen right. Okay. So if you are leading a service, these are the things I've picked up in the 2.5 years, really, to try and increase your comfort zone. It's about improving the level of preparation, meeting the people involved in incidents, that includes consultants, avoiding the assumptions we talked about, recognizing people's defenses, positions, and that includes people shouting at you, blowing a gasket. That's just distraction. That's not about answering the question. They just want to move you away from what you're looking for. Agreed processes for managing poor behavior, and just being focused on what you need. I think the last point is crucial, the quality of your listening. When you're listening to your team, how well do you listen? How long is it before you say anything? Do you think about what they say to you before you actually respond? In terms of making changes, these are probably some key things about making impact changes and linking them to the things. Because we always do an RCA and we always tweak something that wasn't quite tweaked before, but does it actually really matter? Do we need to change something if it's not broken? I think the key thing for us that we've changed has been our training and bringing patient stories into the training to make them more real. Okay. In terms of the learning processes, these are what we've done. I think the crucial one is at the bottom, really. And that it's about being ready and prepared and having the mindset that you're going to learn from failure properly rather than demand perfection. Okay. Just a few notes on some of the theory behind this. Okay. You may think that this is like highbrow. This translates into medicine perfectly, trust me. Okay, this is Lencioni's team's dysfunctions of any organization, and where you've got an absence of trust, people will not challenge, people will not commit. Without commitment, you can't have accountability, and without accountability, you can't have results, okay? You need to build that pyramid up to actually be able to change things. And in terms of leadership, you've got your resonant leadership, which is probably the best thing, really, in terms of, this is about understanding where you are in terms of emotional intelligence. It gives you a script of different leadership styles to actually have. The more leadership styles you have, the better leader you'll be. If you've just got one size fits all, you're not going to be able to flex for different situations or adapt, or actually be able to actually move between situations and understand which tool fits best, really. Okay, so these are the things that I'd encourage you to think about developing. Nice quote from Angela Mayo. And I think these are my challenges to you, really. Do you know your assumptions? How many styles of leadership do you actually have? How often do you give your team positive feedback? Are you process or output driven, and how well do you think your team's functioning? Can you actually define that? And how mature do you think your investigations and culture are? Okay, thank you very much.
I know that bit. Can we have the slides, please, of my talk? I already know who I am, funnily enough. Thank you very much. So I'm just going to concentrate on 4 controversies. 3 are in your program already, tocolysis, but I felt I ought to put something in about magnesium sulfate because this is a very developing area. Mode of delivery and antenatal steroids, which has been a great concern of mine just recently. Now, the RCOG, back in October 2002, actually made a very important statement regarding tocolytic drugs, out of which the drug companies had made a huge profit in the previous 10 to 15 years. What did they say? It is reasonable not to use tocolytic drugs. There is no clear evidence that they improve outcome. And that was really a sea change, and we've hardly used any tocolytics since then, and anyone who does has to be very careful because they can kill people. We know that, for example, beta-sympathomimetics have been responsible for numbers of maternal deaths and so on. The only time really it's justifiable to use a tocolytic is if you're transferring someone for higher level care, or if there is need to delay delivery for a few hours in order to allow steroids to work. Those are the only indications for which it's now valid to use tocolytics. So anyone using them outside those indications, where there is an adverse outcome, is all immediately legally liable for any adverse outcomes. What about, you might say, bring it up to date? This is from February 2011. This is the latest guideline. It says exactly the same thing. There is no significant effect, there's no evidence. Not using tocolytics is entirely acceptable. What about the American College? Well, this is their practice bulletin from 2012, which has actually been updated in January 2016, so a recent comment. In the absence of maternal infection, you can consider tocolytics just for maternal transport and steroid administration. End of story, nothing else. That's the only indication. No evidence exists that it has any direct favorable effect on neonatal outcomes. Okay, so this is an unfortunate chapter in our history. They were used with great enthusiasm. They did a lot of harm. Now they should be very severely restricted. This is a recent meta-analysis from just 18 months ago, and if you look at all the different categories of tocolysis, whether they're COX inhibitors or oxytocin receptor antagonists such as atosiban, they do have no effect on perinatal mortality. There is insufficient evidence in relation to calcium channel blockers, but there's no suggestion that they are any different. Now, just look for a moment at magnesium sulfate. We know that it is of no value as a tocolytic, which is why it was introduced. However, there was an important meta-analysis done in 2009 which showed that although it had no effect on the immediate outcome and certainly was not effective at stopping labor, it did seem to have a protective effect against cerebral palsy, and there's about a 30% reduction in the long-term incidence of cerebral palsy, which is not related to the obvious immediate intrapartum events. And it may be that what the magnesium sulfate does is stabilize the cell membranes in the brain and afford some protection against hypoxia. Now, if we move back to 2011, the Royal College produced a paper, scientific impact paper, and acknowledged that this effect may be valuable and indeed greatest at very early gestations. And there didn't appear to be any adverse long-term effects that could obviously be identified, some minor adverse ones. But what they did say, at that time, the data had not led to a widespread change. There was one study which turns out not to have been substantiated, which made people a little cautious. And they pointed to the lack of evidence, and a recent opinion paper from the American College, which supported it, but was a little equivocal. So let's look at that committee opinion. This is now from 2015, so that's quite recent, so within the last 18 months, already affirming that magnesium sulfate appears to be advantageous, but that it should be used carefully in defined circumstances, ideally within a trial. The neonatal edition of the Archives of Diseases in Childhood also commented that it's not yet been established widely in UK practice, but nonetheless advocating that it should be more widely considered. And in fact, in preparation for this talk, I actually emailed close colleagues who I know have good information, literally within the last 10 days. And I got back these comments from they all replied, and you can see there that there are 7 hospitals that I got information from in the UK and 4 in the USA, and without exception, they are all now routinely using, and you are as well, yes, okay, so that's now 8. So it does seem to be that within the last 18 months to 2 years, there's been a major sea change in opinion, and it's now being routinely used in the UK and in the USA. But interestingly, just literally since I've been here, in the last 24 hours, I got an email from my research fellow in Denmark answering the same question, and she said that at the moment they're not routinely using it in Denmark because nearly all the maternity units are taking part in a multi-center randomized trial of magnesium sulfate for neuroprotection. So that's the reason. So this does seem to be something that we should all be seriously considering implementing as a routine. Moving on to mode of delivery. I actually, with Zoe Penn, who's now the clinical director of our hospital, did a randomized trial many years ago about the mode of delivery of the preterm breech. And we then did a systematic review of the controlled trials 20 years ago now. And in fact, you can see that the most striking factor with all these trials is the very low numbers of participants who were randomized. And we actually discovered that the reason for this was not because the women would not agree to be randomized into trials, but that the consultants always knew best, and they decided we should do a cesarean or we shouldn't. And they didn't actually randomize people who'd already agreed to be in the trial. So it proved to be very, very difficult to get a scientific answer to this problem. But if we actually look at the outcomes in those few that were randomized, we can see that there were slightly fewer deaths and some maternal complications if you did a cesarean, but actually there was less acidosis and far fewer important maternal complications, which is important because doing a cesarean section at 26 weeks with an undeveloped lower segment is quite challenging and can lead to major maternal complications. And they were highly significantly more likely to have major morbidity if they had a cesarean section. So you've got to balance the fetal risk against the maternal risk. And just to give you 2 simple illustrations, we had 1 stillbirth in the vaginal delivery group in our trial, but 1 baby where the mother was allocated to conservative management turned out not to be in labor. And that baby, from having a perinatal mortality risk of perhaps 60%, delivered at term a perfectly healthy baby. So one of the disadvantages of cesarean sections is that you may be delivering some babies unnecessarily because of the difficulty of diagnosis. Bringing us really up to date now, this is just from the last 18 months, a meta-analysis of mode of delivery in vertex presentations in small babies, and you can see the little diamond at the bottom still overlaps 1. In other words, there is still no scientific evidence that routine cesarean section is of any benefit. So our conclusion must be that we must allocate delivery based on the individual clinical circumstances. There is no benefit in automatically delivering these babies by cesarean section. There's no scientific basis for that. Here's another study from 2015, a recent study looking at the long-term outcome. And to cut a long story short, because we're under pressure of time, I can simply say that if you compare vaginal delivery with cesarean section, there was no significant difference in any long-term outcome. So again, no justification for routine cesarean section in these cases. So I'm going to finish by talking about something which has been concerning me and a number of my colleagues for a long time, and that's the use and indeed abuse, as with oxytocin, the abuse of antenatal steroids. Liggins and Howie showed many, many years ago, we're talking 40 years ago now, that in very preterm labor, if you gave the mother steroids, there was a significant reduction of the incidence of RDS, and more importantly, there was a significant reduction in neonatal deaths. And the reduction in neonatal deaths was about 40%. So it's a substantial reduction in mortality, justifying the use of steroids in these very preterm cases. This was a meta-analysis in 1996. But in the subsequent 20 years, we've discovered that there is no such thing as a free lunch, unless you're at this Congress, of course. Hopefully you've already paid for it. There are risks of antenatal steroids which have become apparent. And let's just briefly run through those. We know that in animal models, fetal sheep, if you give the sort of doses which are 3 times the sort of dose that would normally be used in cancer cases, so it's a massive, what I call an industrial dose of steroids that we usually give the mother, that this will stop neuronal migration in its tracks for up to a week. So they definitely impair the development of the brain in some way. We know that in humans there is now conclusive evidence that babies who've been given, mothers who've been given steroids have reduced growth and a decreased birth weight. There are also studies showing behavioral changes in children at the age of 3 years. We know also that this massive dose of steroids can alter the setting of the hypothalamic-pituitary axis, and these babies have higher insulin resistance and raised glucose levels as a consequence, leading to the increased risk of diabetes. And we also know that this is linked, this maladaptation, to the incidence of hypertension in both in adolescents and, as you'll see, in older people too, if they've been given steroids in utero. Now, this is a huge indictment of the tendency of obstetricians to rush into things without actually assessing the evidence properly. Because, of course, if one course of steroids was good, a la Liggins, then multiple courses must be even better, mustn't they? And in fact, I'm ashamed to show you this paper from my colleague, close colleague, Peter Brocklehurst, published in 1999. He carried out a survey of practice in the UK 20 years ago. 98% of maternity units were simply giving women repeated doses of steroids if they thought they were at risk of preterm labor, without any evidence to support this whatsoever. It was an absolute scandal, and I'm afraid this has happened, everything from diethylstilbestrol to thalidomide. This is just another example, I'm afraid. And is there benefit of harm? The first papers started to show that there were no additional benefits, and then they started showing increased risks of perinatal infectious morbidity and neonatal death, decreased fetal head growth, the babies are smaller, and if you look at the outcome, at 5 years of age, there were no benefits. And the key thing is, if the mother wasn't actually in labor and didn't deliver preterm, and those babies went on to term, there was a 3.7-fold increase in the incidence of neurosensory disability. So if you're giving lots of women in case they're in preterm labor, the women who are not in labor, you are damaging their babies, and they will have a significantly worse outcome. So this means we've got to be very careful when we give steroids to make sure that we really are giving it to women who are in proper preterm labor. Just spraying it around is a dangerous thing, and in future you may well be sued for adverse outcome if you've done that. Okay, so the Green Top Guidelines from 2010 from the Royal College, when should you repeat the courses of steroids? And the answer is you should only think about it under exceptional circumstances. Weekly repeat courses are not recommended. Class A evidence. You mustn't do it. The only time it's possible is if you've made a mistake the first time and the woman wasn't in labor, but now she's definitely in labor with ruptured membranes at 3 or 4 centimeters, then it may be permissible to give a second course, but that's it. You've got to be really careful before you give recourses. What about a single course? Well, we're now in a situation where the original Liggins cases can be followed up to the ages of 30, 40, and so on. So they are being followed up. And this particular group, this study, which was published more than 10 years ago, actually looked at participants in their 30s, and what they showed was that in babies who'd been given steroids compared with those that hadn't, there was an increased resistance to glucose, and this is likely to increase their rate of maturity onset diabetes. So even in just a single course, we are now seeing evidence of a long-term harm. And this particular paper, which is published quite in the last 5 years, points out that the long-term effects need greater study. We already know from Peter Nathaniel's work in primates, in chimpanzees, that if you give steroids to the mother, you can follow the effects, not just in the children, but in their children's children. It goes down the generations by resetting homeostasis levels. So even the grandchildren can be adversely affected. So we should be using the lowest dose that's effective. But of course, we don't know what that is. So we continue to give doses which are probably massively greater than actually are needed to produce the benefit. Let's look at the latest guidelines from 2010. There are no known benefits for the mother. You should only give a single course of antenatal steroids between 24 weeks and 34 plus 6. That's now been reduced to 34 in most guidelines. There's no evidence of long-term benefit after 34 weeks. Certainly shouldn't be giving them before preterm, before cesarean sections, for example, at 39 weeks. If we look at the latest guidelines from the National Institute for Clinical Excellence in the UK, November 2015, you now see 26 to 34. That's 33 plus 6. So you've brought it down a week, and you have to have either a planned preterm birth or really good evidence of labour. Do not offer repeat courses. You need to discuss with the woman the long-term effects of the adverse effect on the baby if the mother turns out not to have been in labour. Then that was going to be harmful. Not so harmful, but there are problems. The potential risks have to be discussed. If we look at the interim update of the American College, again, January 2016, a single course of corticosteroids may be considered in the risk of preterm birth. So again, 24 to 34 weeks. So that's now sort of settled down to a pretty firm recommendation. A single repeat course only if there is a major reason to believe that the woman is now in labour when you've made the mistake before. Now, this was a very, very important paper which showed the importance of not giving it to babies who are actually not preterm, and also getting the gestational age correct. So the dangers of giving steroids when you're not really sure of the gestational age. This was a very important paper. It was a large multi-center randomized trial, cluster randomized trial of 51 intervention clusters, and this included a very large number of cases, a very important paper, and this was the control clusters. Okay, so we're talking about almost 100,000 babies and women in this trial. And they were trying to give steroids to everybody, so 45% in the intervention and only 10% in the control group. And what was the conclusion? Despite the increased use of antenatal corticosteroids, overall neonatal mortality was not decreased. And in fact, in the population overall, it increased. For every 1,000 women exposed to this strategy, there were in excess of 3.5 neonatal deaths. The risk of infection was increased. So what was the problem? And if we actually look at the results, what we can see is that a lot of it was due to uncertainty about gestational age. If you look at the babies that were actually born small, there was a benefit, as predicted by Liggins. But if we look at the babies that were actually much larger than expected, where clearly the gestation was wrong, the outcome was worse, and those are in fact significant differences. The blue line, babies given steroids, had a higher mortality than the ones not given steroids. An unexpected and unfortunate finding. The intervention resulted in a 12% increase in perinatal mortality in the population. And this harmful effect was concentrated in the large babies. Gestational age-based analysis showed a similar effect for term infants. So it's really a bad thing to be giving steroids to babies after 34 weeks. You increase the mortality, you increase the long-term morbidity. It's not a good thing to do, and in future you may be held responsible if you do it. And if you want to read in more detail, a relatively recent paper just from a couple of years ago with two of my American colleagues, close friends, Alex Vidieff and Mike Belford. So what are my conclusions? Firstly, tocolytics, it was a false dawn. They had lots of promise not upheld. Should only be used to allow transfer or to give steroids for as short a period as possible because they have risks to the mother and therefore to the baby. Magnesium sulfate is neuroprotective. I think the evidence is in. We have lots of really good quality evidence, and it should now be in routine use. There is no benefit from routine cesarean section. You need to take each case on its merits. And finally, in relation to corticosteroids, if you give it in preterm before 34 weeks, it improves the outcome. But firstly, don't give multiple courses. Very dangerous, bad news. Don't give steroids after 34 weeks. They're likely to have an adverse effect and are not beneficial. You don't deliver babies early and then give them steroids just in case. That is very bad medicine. And we need to improve our prediction of babies by using things like fibronectin, ultrasound cervical dilatation screening. We need to be clearer which babies are actually in true labor and those are not, so we don't give steroids and cause harm when we should only be doing good. Thank you very much.
Dr. Preeti, what is your normal algorithm for early or late IUGR, the basis of an ultrasound Doppler? Whether you look for the umbilical artery, middle cerebral artery, and ductus venous in all cases, or first you go on with this umbilical artery, later on, what is your normal algorithm?
Normally, we look at umbilical and MCA in all patients. And ductus venosus, only the umbilical is abnormal.
Few questions. Dose of magnesium sulfate for neuroprotection. 4 gram strat dose followed by 1 gram per hour into 24 hours, or 8 gram strat dose followed by 2 gram per hour. What is the dose one person wants to know about?
Yes, I don't know of any evidence that suggests whether there's any difference in those two dose regimes. So essentially, the results that we have are based on the dose that used to be used for tocolysis. So the current trial, for example, the one that's going on in Denmark, is about trying to determine the optimum dose. It may be that we don't need to give as much as used to be given for tocolysis. So at the moment, I prefer to duck that question and say we need to wait for that further evidence. But the evidence at the moment is that the tocolytic dose is probably a reasonable way to go for the moment. It may be that in future we can use lower doses.
Simon, what is your dose for this thing?
We use the low dose at the moment.
Low dose,
Yeah.
4 gram.
Yeah.
4 gram stat followed by 1 gram per hour. Okay. Dr. Philip, one more question for you. British Medical Journal 2016, an article which shows benefit of steroids after 34 weeks. What do you, why do you not recommend it?
Right. That's the Stutchfield paper, and there's a lot of criticism about it because they showed, firstly, it was a trial where women were being delivered electively at 37, 38, and 39 weeks. And what they showed was an important reduction in RDS at 37 weeks. But the effect was very small at 39 weeks, and my answer would be you shouldn't be delivering at 37 weeks so that you then have to give a dangerous drug. That's the first point. Secondly, in that paper, they only reported the effect on respiratory distress syndrome. And actually, when there were letters inquiring, what about the overall admission rate to neonatal unit, it turned out there was no difference between the steroid-treated group and the non-steroid-treated group, and all they'd done was they changed the reason for admission from RDS to something different, which was usually, for example, low sugar levels and so on. So there was overall no benefit and no reduction in transfer to neonatal unit. It was purely shifting morbidity from respiratory to metabolic. And I don't personally regard that as an advantage. Plus the fact that the dangerous long-term effects of giving steroids, for example, in the Lancet paper, is now so well established that I think it would be difficult to justify doing that. So the key is don't deliver the baby any earlier than you need to.
Can I?
Yeah.
I'd like your thoughts on this, because certainly in a lot of hospitals we worked in and where I currently work, if we're delivering electively before 39 weeks, we're giving steroids, you know, to reduce the incidence of RDS.
Yes, well, the answer is you need to look at the indication for the elective delivery. Is it truly that important to deliver before the recommended time of 39 weeks? And I would say that in women who are South Asian or African origin, I would reduce that to 38 weeks because the babies mature earlier. So 38 weeks is fine. In this country, 38 weeks would be okay. Before that, you need to think very carefully before delivering. Secondly, the other point is that there is no support for that currently within any of the guidelines. So if you look at the college guidelines, the American guidelines, they say don't do it. So if you do it, and there is a long-term problem with that baby, I suspect you may be on dangerous ground in order to try and defend it.
To Dr. Preeti Venkatesh, what is the single best parameter for diagnosing early fetal growth restriction? And what is the importance of presence of diastolic notch? Is it helpful for predicting IUGR?
In the previous question you asked me, I forgot to say that we now routinely do uterine artery Dopplers in the third trimester as well, because that is one of the factors that will help you diagnose late onset FGR. For early onset FGR, you have to do umbilical artery and MCA, because there are cases where the umbilical artery is the first one to become abnormal. There are others where the MCA becomes abnormal first, or only the CPR ratio is abnormal initially. Of course, eventually both will become abnormal because this is a severe disease. I do not know why that question was asked. Which is the one single parameter?
I'd be interested in the discussion. I mean, obviously, I think what we see with early onset IUGR is there's probably two distinct populations, really. There's one that find a level of growth, a low level of growth, and they kind of compensate, you know, quite happily. You know, they find an equilibrium. Whereas there's another group that just never find that equilibrium at all, really. And I think it's about differentiating which one you've got, you know.
Yes, I mean, there are ones that will just go on and on for a long period of time. And if you were to see them later, you're wondering whether this is late onset or early onset. But there are others who have a very steep progression. So you need to look at all these parameters and come to a decision whether you're dealing with a compromised fetus or not. And there are some studies that say that when you first find an abnormal umbilical artery, you repeat it after a week. And if you see a significant difference, then you're probably dealing with a rapidly progressive placental insufficiency. But if the difference in 1 week is hardly anything, then probably it's not such a severe disease.
Agree with that.
So late onset IUGR, do you need to do more frequent scans during the third trimester? Routinely, how many scans do you advise during the third trimester?
I don't think the last word has been said upon that, but what we are trying to say is that there is a group of fetuses here that they are not obviously small, but have a vascular compromise. Now, suppose you had a fetus with increased umbilical uterine artery screening positive in the second trimester, who was growing apparently well. I would not fail to do a repeat scan at 32 to 34 weeks in that fetus to see if that fetus is developing late onset FGR. And if you have a fetus that is clinically small, or you have a fetus that is had any evidence of compromise earlier, you would follow them up. But there is a question, if normally growing babies you want to diagnose late onset, should you be doing a routine scan at 32 to 34 weeks? I have not found an answer to that. Any comments on that?
Yes, there is good evidence that routine ultrasound in otherwise low-risk pregnancies is actually harmful. And the reason for that is that you always have false positive rate, whether the baby is abnormal or not, and the false positive rate is the same in healthy pregnancies as it is in unhealthy pregnancies. And therefore the problem is, if the likelihood of a bad outcome is lower than the risk of false positives, then you end up doing harm, because you end up delivering babies early unnecessarily. And the randomized trials have shown that unless there is a specific indication for doing a growth scan, routine scanning in the third trimester actually adversely affects the outcome. It makes things worse because of over-intervention and unnecessary early delivery. So we need to be very careful. It seems obvious that monitoring the baby more closely may be beneficial, but you've got to remember that it can also be harmful if you pick up something which subsequently turns out not to be correct.
One qualifying thing I would say about that is that a lot of those papers have come from dated populations, and what I mean by that is you know, because of the increase in BMI that we see now in UK population, I think it's very difficult to get an accurate assessment from symphysis fundal height, you know.
Yes, okay. So that's a very interesting point, but what you're saying is it's difficult to establish the situation in women who are obese, but equally scanning is more difficult in women who are obese. And we know that simply looking at size is a very poor indication, particularly in obese women, of whether that baby's at risk. And we've already heard about the average for gestational age growth restriction. Indeed, some of our own studies showed that 50% of babies that had uteroplacental insufficiency were actually within the normal weight range. So just looking at weight is not adequate. You've then got to do a whole Doppler screen, And then the problem is, in macrosomic babies, you can get abnormal pulsatility index because of increased systolic velocities, which are actually reassuring. And so a lot of people would say that in a well-grown baby, Doppler becomes very difficult to interpret because you need different standards than in a growth-restricted baby. So it's a very complicated area. And I think we need to be careful between what you as an expert ultrasonographer might do with your advanced knowledge and what is suitable for a routine population policy where you could end up doing a lot of harm because of errors and poor quality ultrasound.
I think what we're agreeing on is that whatever method we have isn't good enough, really, to, you know.
When there is an indication, yes, of course, but otherwise routine, we are not really sure whether we should be scanning all patients as a routine.
Dr. Steer, with premature contractions, what is your tocolytic of your choice?
None.
None.
They're of no value unless you need to transfer to a tertiary unit or unless you need to delay delivery for a few hours to allow the steroids to work before 34 weeks. Otherwise, they're not only valueless, they are potentially dangerous. Remember that there have been well-documented maternal deaths from the use of tocolytics, so the best thing to do is not to use them, unless those two circumstances.
Do you recommend
that's what all the guidelines tell us at the moment.
Yeah.
So it's not just me.
Yeah. Another added question is whether you recommend vaginal swab antibiotics for preterm labor?
There's no evidence that either of those are of any benefit. The only value of the swab is to detect group B strep, because if you have ruptured membranes, there is a clear advantage to delivering earlier rather than using conservative management if the woman is a group B strep carrier. Otherwise, conservative management is best.
And what's your opinion regarding giving steroids for mothers undergoing elective cesarean at 39 weeks? It is recommended to prevent transient tachypnea of the newborn.
Yeah, but it increases all the other problems that I've discussed, like abnormal glucose tolerance, blood pressure changes in adolescence, and so on. So there is now very good evidence that if you're doing that, you are medico-legally at risk. Hopefully you may have retired or possibly even died before those cases come to court, but somebody is going to be held responsible.
Yeah.
Bad thing to do.
Can I ask a question on that? Because a lot of those, the altered glucose axis, the hypertension, they are linked to fetal origins of adult disease, which are linked to things that indications that you would normally give steroids for. So how are you disentangling causation there? You know?
The disentanglement is coming from the follow-up studies of the randomized trials.
Yeah.
And we know that the purpose of randomization is to actually standardize these confounding factors between the two groups.
Yeah.
So we can be pretty confident that the only difference is the fact that one group had steroids and the other group didn't. And I think the Lancet paper was a really important warning, very, very important paper, that you've got to be very careful and very specific about when you give steroids. Otherwise, we'll be back in another diethylstilbestrol, thalidomide sort of problem, where I always say to my students, do you know how many babies had their reproduction potential destroyed? That's 50% of women and 50% of men, which is not often remembered, from methylstilbestrol. And the answer was 4.5 million were damaged before it was realized it was a bad thing. And with thalidomide, you'd think babies being born with no arms and no legs would be pretty obvious. You know how many cases it took before the damage was realized? 10,000 babies. I don't think we should be in the same situation with steroids. We know better, so we shouldn't be doing it.
So thank all the speakers.
I have a question. Very often I find when I'm monitoring these patients for growth restriction, the obstetrician wants to give steroids because in case tomorrow the parameters fall and they have to deliver in an emergency. So what do you say about that?
The answer is we've got to learn to practice medicine on the basis of solid information and fact and what is correct for the patient, and not on the individual whim or gut instinct of an obstetrician, which we have been shown many, many times in the past are wrong and dangerous. This is not the way to practice medicine. It should be evidence-based. And I'm sorry, but I'm unapologetic about that, because too many people have been damaged by care which is not evidence-based.
Thank you for that wonderful discussion. We have a memento for Dr. Preeti Venkatesh. Madam. And also a small gift to Dr. Simon Cunningham and Dr. Steph Phillip. Thank you so much.
Dr. J. Krishnan and the entire team advances. Ladies and gentlemen, I intend talking to you not about the whole gamut of twin pregnancy, but only on its labor and delivery, okay? Now, before I start my topic, I thought I'll have a quick recap of what you and I know. One is that we allow a vaginal twin delivery only when the first is a vertex. We look only at the first. Okay, we don't look at the second at all to decide our mode of delivery. We look at the first, and if the first is a vertex, yes, there's a chance for vaginal delivery. The second thing we think of is, whenever we talk about the management, it's only about how are we going to manage the second, not the first. Okay? So all our controversies will come in only for the management of the second. The third is, which you and I know, we do not like to increase interval between the first and the second. We like to keep it as low as possible, and preferably within 30 minutes. Of course, there is another thing when there's an electronic fetal monitoring, but otherwise we like to keep the interval between the two as short as possible in order to give better chance of salvageability to the second babe, okay? The next thing I wanted to tell you was, when first is a vertex, we deliver the vertex. We all know how to deliver the first. Now the second is also a vertex. What do we normally do? We do one of four things. Either we give oxytocin to augment, and then the head comes down, the second head comes down and is born. Sometimes after the head enters the pelvis, we do an ARM, 2, okay, only after it has entered the pelvis. The third thing which you can do, and which is permissible today, is you can apply a vacuum for a high head. The only indication for a high head vacuum is for a vacuum for a high head is in the second of a twin, but we apply a small cup, not the big cup, okay? And the fourth, which is extremely rare, is when the head is very, very high and you are so desperately wanting to deliver it, you can do an IP version under general anesthesia and deliver it, which is, I would say, a very remote possibility, okay? So these are the four things which we think of when we think about a vertex in the second, okay? Now, what would you think of if the second is a breech? Now, there are only two options. We believe that whenever the second is a longitudinal lie, it is best that they deliver vaginally. Remember that as a dictum, okay? Because the second option for a breech would be, we do an external cephalic version. So those are the only two options when the second is a breech. So, but we prefer today, as I will tell you what evidence tells us, that it is best that when it's a longitudinal lie, even if a breech, the second is best delivered vaginally. The third problem comes in when second is a transverse lie. Okay, now when the second is a transverse lie, you'll realize we've got again two options. Either we do an external cephalic version and allow the baby to be born as head, or we do an IP version and a breech extraction. And I will be telling you now what evidence says that compared to the two, the external cephalic version and the IP version and breech, we go for the IP version and breech extraction, okay? So this is what the fundas we already know, and now we'll move on. Now, most of our twins, they're normally preterm twins, about 50%. So the decision is taken off you, okay, as to when to deliver the babe. But in the remaining 50, in the absence of a spontaneous preterm, the optimum time to deliver, it depends upon the chorionicity and the amnionicity. Now, I'll take you to a quick recap, okay? I just drew this diagram now. You look at this first diagram there. The outer ring is a chorion, and the inner ring is the amnion. The outer ring is the chorion and the inner. So they are dichorionic, diamniotic. Forget about them. So you can forget about a lot of patients because you don't require much of care for a dichorionic, diamniotic because each has got its own placenta. Each has got its own placenta, and so you will realize that you really don't have to even monitor so carefully as you would the second section. The second segment, this is when the division takes place before 4 days, okay? Now when the division takes place before 4th and the 8th day, you will realize it's a monochorionic and diamniotic. Meaning to say, to put it in very simple terms, you will have to rupture the membranes twice. You got what I'm saying? But each in his own sac, except that it's got just one chorion. Then of course we come to the Momo twins, which is a monochorionic and the monoamniotic, meaning to say that both are lying within one sac. Okay? So that is the one which again you can forget about that, because around 34 weeks it is best that we terminate them electively as cesarean section because of the cord entanglement. And when I tell you cord entanglement, it is more fine than even the rope. Do you understand? Because the cord gets entangled so much. So many times you might lose the babe. So you should avoid a vaginal delivery. And the best thing to do would be to allow her to have a cesarean section at 34 weeks. So the only one we have to really monitor is the monochorionic and the diamniotic twins. Okay? Now, although the systematic review in 2016, don't read that, but the recommendation is that in an uncomplicated, now remember this word uncomplicated is important, because if you've got a preeclampsia or if you've got diabetes, etc., you may have to deliver them earlier. But in uncomplicated dichorionic diamniotic, I said forget about them, right? You deliver them around 38 weeks. Okay, 38 weeks and 6 days. So just remember that don't take them too long, because twins mature earlier than singleton pregnancies. Now, again, look at the second part. If you take a monochorionic diamniotic twin, it's best that you deliver them around 37 max. Okay? So if I give you a period, it will be 37 to 38 weeks dichorionic, 36 to 37 weeks. So in order to remember better, all the dichorionics not later than 38 weeks, all the monochorionics uncomplicated not later than 37 weeks. Okay? Right. Now, what are the options for a twin delivery? Yes, you can straight away do a cesarean, but it is said that when the first is a vertex, there is no advantage of doing a cesarean. Please remember that, okay? The vaginal delivery for both, either you deliver them both by cesarean or both as vaginal, that's fine. But don't ever go into this format of delivering the first as vaginal and the second as cesarean. This is what is called a combined, and I'll tell you why, okay? So it's best either you take a decision and do off a cesarean, or you do a vaginal for both. In spite of all what I've said, cesarean is still the commonest mode of delivery in a twin pregnancy. 60% of twins are born by cesarean, okay? Now what would be your indications for a cesarean? Straight off cesarean, okay? A twin the twin A being non-vertex. I told you we allow a vaginal only when the first is a vertex presentation. I'm just oversimplifying it for you all. Now, when the estimated fetal weight of, you heard Professor Steer tell us this, that if it is less than 1,500, yes, they say it's best not to allow a vaginal delivery. Now, he gave me a little food for thought. And when the second is more than 500 grams larger than twin A, so it is good for you to know the weight of the babes at birth, okay? If the second is less than 1,500, it's preferable that we do off a cesarean. And if the second is larger than, that is 20% larger than the first, it's best that we do a cesarean. I'll tell you the evidence for that. All the Momo twins, I told you 34 weeks, we do that. Conjoined twins and other obstetric indications. Monoamniotic twins, as I told you, cord entanglement, malpresentations are more common. Inadvertent cutting of the cord of the second twin, and so it's prudent to deliver them by 34 weeks, electively as cesarean section. And let me tell you something, probably when I asked once a sonologist, she told me, I have never seen a monoamniotic twin. So it's an extremely rare thing to see a monoamniotic. There is a monochorionic and a monoamniotic. Now, sonographic evaluation, why before labor? First is for the fetal presentation, because I told you once, the first is a vertex, only vaginal, okay? Otherwise, if it is, I mean, if you've got some other indication to do a cesarean, you do it, but if at all you're allowing a vaginal, first should be a vertex. And the fetal weight. Now, the reason I told you for the fetal weight was when the second is less than 1,500 or when the second is 500 more, it may be better off to do it. Now, what is your preparation for any delivery, vaginal delivery? We have good to have an IV access, need not be a drip even. Have a cannula there. Keep blood ready because you're prone for atonicity. Postpartum, oxytocin to be kept ready. Anesthetist, obstetrician, neonatologist. Obstetricians experts in inversions and breech extractions. Facilities for an emergent cesarean section. Early epidural, okay? Portable scanner and a CTG with a dual monitor. Don't use a single baby's monitor for both the babes. It's better to have the dual monitor CTG machines. Now, the route. If women with twin pregnancy with a presenting twin in cephalic presentation should be counseled to attempt a vaginal delivery. The 2011 systematic review planned cesarean does not significantly improve neonatal outcome or early childhood outcome as compared with the planned vaginal delivery. Now, vertex and vertex, the general consensus is that a trial of labor with the goal of a vaginal delivery for vertex and vertex twins is appropriate at any gestational age, at any gestation. You heard Sir say some time back, there's no advantage of delivering a preterm by cesarean, which most of our neonatologists would push us to do, okay? After twin A, what? As soon as the first babe is born, okay? That was a vertex presentation, as I told you all. Immediate assessment and lie of the babe by abdominal palpation. Then you do an intrapart, that is you do an ultrasound to assess them, to assess for maneuvers. If vertex or a breech, give oxytocin and amniotomy, and when the presenting part enters the pelvis, you can do an amniotomy, meaning to say if the second is a longitudinal lie, you can allow a vaginal delivery. Without any versions, assisted delivery if needed, and breech extraction may be needed if there is a delay. Now, twin B remaining high, you can give oxytocin, what I told you some time back, you can do an amniotomy after the head enters the brim, you can apply a ventouse, or you can do an IP version, and breech extraction may even be considered. Because you know the reason why this IP version, breech extraction is given so much of thing, because supposing for whatever reason, supposing it's a breech and you've done an external cephalic version, the head is still high. It's going to take time for that head to come down, isn't it? On the contrary, when you do an IP version and a breech extraction, the time, you have actually shortened interval between the two because you do both immediately. You give her anesthesia and you go, but remember, LICA should be there. Without LICA, don't ever attempt an IP version. A non-vertex presenting twin, okay, 20% of the twins, best recommendation is a cesarean straight away. I told you some time back, if this first is a non-vertex, best to do a cesarean section. If the vertex, non-vertex, the first is a vertex, but the second is a non-vertex. The reason why we don't look at the second when we're looking at the first is because many times the second can change its position. Do you understand? That's why we don't look at the second. We only look at the first. So with presenting twin vertex, the ACOG considers the vaginal delivery a reasonable option regardless of the presence of the second fetus, provided an obstetrician who's got experience in an IP version and a breech extraction, etc. is available. Successful vaginal delivery appeared to be less likely when ECV was attempted than when breech extraction was performed immediately after delivery of the presenting twin. Now, I told you some time back, when it's a longitudinal lie, you can allow to be born as breech, right? But there may be situations in which the breech is still very high. Then you give anesthesia and do a breech extraction. You understand? ECV was completed in 40 to 50% of cases, and the remainder was delivered by cesarean, while the breech extraction followed by vaginal birth succeeded in 96 to 100%. So this is what I told you, you can do a breech extraction, look at the success in delivery rather than go for an ECV and then wait for that head to come down, okay? Now supposing, I told you some time back for a transverse lie, I said we've got two options, external cephalic version or a IP version and breech extraction, or a combined delivery, that is doing a cesarean for the second. Normal teaching has been to try an ECV, that is for the transverse lie, and if it fails to go for an IPV. But there is a shift in current thinking, as the risk of a combined delivery is 42% with ECV and 2% with IPV, meaning to say that after you have done the external cephalic version also, you may land up doing a cesarean section. Do you understand? So that is when and why is it that we do not like a combined delivery? When ECV is not recommended, success rate with ECV is similar to a singleton, but adverse outcomes are probably because of increased chance of prematurity, advanced cervical dilatation, and limited experience with intrapartum version. Hence, IPV and breech extraction is a safer option than ECV. Now, indications for cesarean. Now, when do we go for a combined? That is, I've done the first vaginal delivery. Maybe suddenly there was a cord prolapse, or there was a fetal distress, or the placenta started separating, or the head is very high and the cervix has started shrinking. The longer the interval, the cervix will start shrinking. Or there's a malpresentation. In all these conditions, maybe we may have to go in for a combined delivery. Okay, that is inevitable. Now, the combined delivery. The morbidity was higher for twin B following a combined delivery than after a vaginal. Why? They compared the 5-minute Apgar, the mechanical ventilation and the seizures, and all were comparable with vaginal or cesarean of both twins. But there was, when you did a combined delivery, there was a low Apgar and a need for mechanical ventilation which was doubled and a seizure rate 5-fold. Therefore, it is best that we avoid a combined delivery, because apparently the interval goes longer and you find that there's an increased incidence of low Apgar at 5 minutes, mechanical ventilation and seizures in the second babe, okay? So either you do both vaginally or both cesarean, but try to avoid a combined. Now, can we have a way back? Way back in twins is okay to give a trial as in singleton, provided they go into spontaneous labor. That's the best, okay? Now, so closely watching the fetal heart, because all of us know that when the scar gives way, the first thing to tell us is the fetal heart, even before the maternal pulse. So if you can actually closely monitor, then of course you can go ahead with a VBAC. Labor in multiple pregnancy, is it faster or slower? We do not know. There has been a lot of conflicting reports, though I would say I find it a little faster. Though oxytocin for augmentation induction of labor appears to be effective, you can augment labor, okay? Electronic fetal monitoring preferred in twins, as intermittent auscultation is not practical and may not reliably distinguish one from the other. Preferable to have 2 traces, and electronic fetal monitoring particularly useful after delivery of the twin A, because it is said that when you electronically monitor the babe, the second baby, then you will realize that the interval, even if it's a little longer than 30 minutes, it really doesn't matter so much, okay? So if you've got access to electronically monitoring the second babe, then the interval being a little longer doesn't matter so much. Now, would you give analgesia? Yes, generally recommended as it provides a good pain relief. There is no neonatal depression, and it is good for any intrauterine manipulations, so you can give an epidural for these patients. Many deliver twins in an operation room because after the delivery of twin A, maybe you will have some problem and you may have to have an emergency cesarean section for cord prolapse, a non-reassuring trace, or for a breech extraction, whatever, or for an IP version and breech extraction. Clamping of the cord. As soon as the first baby is born, we clamp with 1 clamp, 2 for the second, and so on if you've got a third. If in all monochorionic twins, it is important to promptly clamp. That is important. If it is a monochorionic placentation, if you delay the cord clamping for the first babe, then actually the second baby is losing out on blood, okay? So it's after the first, it is best that you immediately clamp, because there could be immediate hypovolemia into the placenta or to the outside, okay? Now, second twin at a greater risk, it may be due to lower, always a second twin is at a greater risk than the first, okay? And we normally count, if there are more than 2, we always count them in the anti-clockwise direction. Twin A, 2, 3, like that, okay, in anti-clockwise. So always a twin A is at a, and twin B is at a greater risk because of the low birth weight, increased malpresentations, manipulations, cord prolapse, abruptio, and interventions. Now, the interval I told you is best if less than 30 minutes, but if there's electronic fetal monitoring and if the trace is reassuring and if there's a real-time ultrasound available, we can wait longer. Can you give oxytocin? Yes. For augmentation of labor after delivery of the first twin, reasonable and recommended due to the weaker contraction frequency after the first twin. So you can give epidural, you can give oxytocin. Now, options for a delayed delivery. Now, what is this thing called delayed delivery, okay? Sometime back, one of my colleagues, his brother was in the United States, and he was, his wife was being investigated for infertility, and then she conceived after a lot of investigations. And then when she reached around 22 plus weeks, she suddenly got into labor, and she was ready to deliver the first twin, okay? Now, we all know that's a pre-viable state. So there is something which is called a delayed delivery. So he told me, ma'am, they have delivered the first and they want to hold on to the second so that to give it a little chance of viability because it's a very precious babe. So I told him, in my mind only 2 things come. One is there's always a chance of infection, okay? And there is always a chance that there can be an abruptio also because the placental site will reduce and she can go for an abruptio. But all the same, it was such a tremendous risk, and the decision they had to take, they decided to continue the pregnancy. So after the first, you can, between 23 and 26 weeks in the pre-viable state, there is an option. I have not done it, I must confess. It's a tremendous risk with your heart in your mouth. You can do a high ligation of the cord, okay? That first babe has come out, and then you can do a high ligation of that cord. You can give steroids, as Sir was saying. The only indication when you can give 2 doses of steroids is when before 26 weeks, and otherwise no other indication for the second course. So you can give corticosteroids and get the babe ready. Antibiotics, of course. Tocolysis is usually a short-term tocolysis and a placement of a cerclage. So after the first babe has come out, they put a cerclage so that they can hold on to the second baby in utero. And should you hospitalize these patients? Yes, it's a big query. No optional strategy, and hence best individualized according to the wishes of the parents and the condition of the mother and the remaining fetus. So they did carry on the pregnancy till about 28 weeks, and that child is now about 2 years old or so. So there is a place for for a delayed delivery, but I don't know. I think it should be in the best of centers, and it is still in a very early stage for us to say whether we can do something like that. But if at all you opt for a delayed delivery, it's only between the pre-viable stage of 23 to 26 weeks, so that you give the child a chance for viability and then to deliver the babe. Thank you.
Good morning, everybody. The topic given for me is cesarean section at full cervical dilatation. As you know, we are doing so many cesareans. Everybody thinks cesarean is so easy. In our country, especially, cesarean is done not only by the obstetrician, but the general surgeons also do cesarean left and right. And you may do so many cesarean sections, but sometimes, once in a while, you will be caught up. You will be in deep waters. You don't know what to do. And when a call comes to you to do a cesarean section at full dilatation, actually, our heart will stop for 1 second. We don't know what, we are in a turmoil, what are we going to face, how will you do it? All these things goes through your mind. So that is the relevance of this cesarean section at presentation, because as you know, cesarean section at full cervical dilatation is always a challenging procedure. It is associated with so many problems: high rate of maternal morbidity, fetal morbidity, maternal mortality, and also fetal mortality. Sometimes even in a primary gravida, we may have to go for a peripartum hysterectomy to save the mother. And as well as later on complications. Future pregnancy also, she may have so many problems. With the scar, when you do a cesarean section at full dilatation, the scar is very unhealthy. So in next pregnancy, it can go for scar dehiscence even during pregnancy, cervical problems because of the cervical injury, so on and so forth. So let us go through what is the incidence of full dilatation cesarean section. What are the contributing factors? Why you have to do cesarean at full dilatation? What is the impact of the cesarean on mother and neonate? How to reduce the rate of full dilatation cesarean section? Tips and techniques to perform CSE if you have to do it, and take home messages. So as you know, the incidence is varying from 2.5 to 3 in Western countries, but as we have no particular statistics, here it goes up to 30%, and in some states even more than 50% cesareans are recorded. And if you take the full dilatation cesarean section, it goes to 4.5% to 6% of all cesarean sections. If you take only the emergency cesarean section, it contributes to 12 to 28.5%. But the interesting factor is that there is reduced or no attempt at all for instrumental deliveries. If we analyze cesarean section and instrumental deliveries, the rate of instrumental deliveries is drastically coming down. And even if you do an instrumental delivery, the failed instrumental deliveries are on the rise. So that is the most common reason for this. And what are the factors contributing to increase this full dilatation cesarean sections? The increasing rate of primary cesarean section itself is one factor. As the rate of cesarean section is increasing, we may have to do more and more cases in full dilatation. And second most common is the rarity of operative vaginal deliveries. Now the operative vaginal deliveries are coming less and less, so we have to do many cesarean sections. Previously, what cases we used to deliver by vacuum extraction or forceps, now these are replaced by cesarean sections. Many fetuses with deeply engaged head that could have been managed in the past by forceps or vendos when are presently delivered by cesarean section. In fact, nowadays cesarean section is performed as an alternative to operative vaginal delivery. Why this happens? Because we are not confident. Our young junior staff is not confident to do operative vaginal deliveries. And you see, Many observational studies, both prospective and retrospective, shows that the second stage decisions are taken mainly by the junior staff alone. As you know, delivery can take place at odd hours in the night, isn't it? So they have to take a decision whether to go for an instrumental delivery or a cesarean section. And lack of training and supervision of junior staff in the second stage decision making and deliveries, that is where we lack. There is no proper training or supervision of the junior staff in second stage. Is very, very important in making second stage decision making, because second stage disimpaction may be due to cephalopelvic disproportion. It may be due to malpositions. So we have to differentiate between this. If it is to cephalopelvic disproportion, definitely we have to go for cesarean section. If it is a malposition like deep transverse arrest or occipitosacral position, etc., pelvis is absolutely normal, then we can have an operative vaginal delivery. That is where the decision making is very, very important. There are concerns about the junior staff who are not confident to do instrumental vaginal deliveries. They are more concerned about the associated maternal and neonatal problems, and also associated litigations and medico-legal problems. In, whatever happens, they will go to the court, all these medico-legal things. And they think that cesarean is a better option than instrumental delivery. And another factor is non-availability of senior obstetrician. In the night, they won't get the senior obstetrician for your support or your help. So non-availability of senior obstetrician is another contributing factor. The crucial decision in the second stage regarding instrumental delivery or cesarean section, I told you, should be taken by a senior consultant. The chance of achieving vaginal delivery with a consultant present in the second stage is reported to be 70% compared to 30% in their absence. So you know the importance of the input of the senior obstetrician in second stage decision making in the second stage of labor. If the senior obstetrician is not available, though the juniors are not reluctant to proceed with the instrumental vaginal delivery, then they have to go more and more cesarean sections. There's another report that a senior obstetrician attended only 40% of these deliveries over the last 3-year analysis, where in 30% cases only the consultant vaginal examination findings agreed with the trainees. The junior staff and the consultant vaginal examination findings, if you compare, only 30% were in accordance, agree, because they are not so much practiced or not much trained to do this. And according to the RCOG good practice guidelines, now the consultant presence at trial of instrumental delivery or cesarean section at full dilatation is now mandatory. So supervision and training of junior obstetric trainees is an important factor in the molding of junior staff. And another contributing factor for this is overjudicious diagnosis of labor errors in the second stage of labor. So the criteria laid down for the duration of second stage of labor is seldom followed. Please understand the second stage starts from the full dilatation of the cervix, and there is an active phase and a passive phase. The passive phase is when the head further descends, it undergoes rotation. So you have to give time for all these things. As soon as the patient is fully dilated, don't shift the patient to the labor cord, start on oxytocin, give fundal pressure, ask her to go on straining, because you will be just like beating a tired horse. So give her time to come over her exhaustion, to get her calories retained. All these have to wait, and only when the patient is in active phase, you have to conduct delivery. That is the perineal phase, and the patient herself will start pushing. So the bearing down contraction starts, then only you go and conduct the delivery. And labor errors in the second stage should be diagnosed if there is no progress in either descent or rotation of the presenting part. Give ample time, and there is no further descent or rotation of the presenting part with adequate uterine contractions. Now they say we can wait up to 4 hours with a patient who is having an epidural, or 3 hours without an epidural if it is a first pregnancy, primigravida, and 3 and 2 hours in a multi. So if the mother is okay, there is no evidence of fetal distress, the CTG is okay, baby is also in good condition, you can give ample time. Most of the time the patient will deliver. So it is an early decision in the second stage that is another contributing factor. Then what is the impact of cesarean section when you do it full dilatation on the mother and baby? Cesarean section full dilatation is associated with more than, that is a study when conducted, showed that more than double the risk of intraoperative trauma compared to when you do cesarean in the first stage of labor or the. So what are the maternal morbidities? You can have the most important thing, extension of the uterine incision. That is unintentional. Because I wrote unintentional because sometimes when you do cesarean full dilatation, you may have to extend the incision intentionally because we will make it a inverted T shape or you have to make it a J shape. All these are intentional extensions. But unintentional extension of the wound can occur. And visceral injury, the bladder will be distended, the bowel will be distended, so you can injure the ureter, bladder, bowel. Postpartum hemorrhage, both atonic and traumatic postpartum hemorrhage can occur. Then pyrexia, sepsis, wound infection, prolonged hospital stay, and more need for blood transfusion. All these are the associated maternal morbidities that can occur. And neonatal morbidities, birth asphyxia and its following sequelae. Induced NICU admission, need for ventilatory support, multiple birth injuries, HIV, intracranial hemorrhage, neonatal sepsis. Then perinatal mortality will be increased, neurodevelopmental problems for the baby, stillbirth and neonatal death. All these are more when you do it. And laparoileotomy, what is it? Can anybody tell me what is it? Posteriors? Because I told you there is an anatomical distortion. You cannot differentiate between the vagina and the lower uterine segment. Whether the lower uterine segment stops and where the vagina starts. So it is anatomically distorted. So you may put your transverse incision in the vagina, not on the lower uterine segment, and you will be delivering the baby through the transverse incision in the vagina. Sometimes it happens in prolonged labor. And there is some cases you may have to readmit the patient for some hematoma, infections, or readmissions and relaparotomies. Cervical injuries may give rise to future cervical insufficiency. Many near-miss cases and maternal mortality are also associated with when you do cesarean at a late stages, full dilatation. And how to reduce the cesarean section at full dilatation? How can you reduce it? Appropriate management of pregnancy and labor, very, very important. If there is any fetal malpositions, we correct it early. Assessment of the pelvis, fetal weight, and you should always chart out your management problems. You have to chart out how you are going to manage this patient. So management plan is very important. Whether you are waiting for a spontaneous onset of labor or you are going to induce that patient. If you are going to induce, what is the protocol for induction? Are this patient for a trial labor or elective cesarean section? All this goes a good way in helping you to conduct the delivery. As you heard, in judicious use of oxytocin. Don't go and give oxytocin for all patients on all time. And always adhere to protocol management. For you should have labor room protocols for everything, preterm labor, PROM, oxytocin drip, induction. So always adhere to protocol management. We have got national protocols and also institutional protocols you can vary. And techniques for delivery. When you are going to do a full-term cesarean section, always keep in mind the problems you have to tackle. It is a deeply impacted head. As I told you, it may be due to capillopelvic disproportion or it may be due to malpositions. And it is a prolonged second stage CPD or failed attempt at operative vaginal delivery. It is still more. You apply vacuum and try to deliver the baby, you failed to deliver it. You are bringing down a larger portion of the head into the pelvis. It will be again difficult to disimpact that head. And overstretched and thinned out lower uterine segment, more liable for extension. Distended bladder and distorted anatomy. As I told you, you may go and cut the vagina rather than the lower uterine segment. So what are the prerequisites? If you are going to do cesarean, proper counseling of the patient and relatives. You have to counsel the patient and the relatives what you are going to do, what will be the outcome. Some days you may maybe try to deliver by instrument, back over forces, or we have to go for a cesarean section. Make sure the presence of senior obstetrician, very, very important. When a junior person is going to do cesarean with full cervical dilatation, you should make sure that somebody senior should be there to help you. Neonatologist should be there, anesthetist should be there, senior nurse or midwife who may help you in the conduct of delivery. And anesthetist should be informed that you may need Trendelenburg position. You have to put the patient like that, or you may need uterine relaxants like IV nitroglycerin during the procedure when there is difficulty to introduce your head and manipulate the baby. And OT Most important thing is when the patient is brought to the OP for cesarean section, always do a PV yourself. You have to reassess the patient. You might have taken decision to do cesarean section in the labor room. By the time the patient is in the OT, sometimes the head might have come down, it might have undergone rotation, or it will be an easy vaginal delivery. You can apply a vacuum or forces and deliver the baby. Don't go for a cesarean. So make it sure that you reassess the patient in the labor room, and then only decide upon cesarean section. And you should have good exposure and relaxation. You tell the anesthetist, I want maximum relaxation when I go to do the cesarean, because you may have to do manipulations. Abdominal incision, you can go for phalangeal or Dolcoin incision, but always sure that it is more wider and slightly above, superiorly, not just above the symphysis pubis. So the skin and facial incision should be wider and more superior. Again, uterine incision is also at a higher level than the normal uterine incision you put. Ends should be curving upwards, and blunt lateral extension. You always use your finger to stretch it. And that is also careful. Don't stretch it like this. You have to say superior and inferior. Superior and inferior go like stretching it. It will not produce much tear. Or you can use that blanket scissors for cutting it. And how to disembark the head. Simple thing is when you do the PV in the OT yourself to reassess the patient, you put in the Foley's catheter. That is the time you yourself can push up the head. It will be, not just push up the head when you put the Foley's, and when you do cesarean, it will be more easy. That is, make it a routine practice. That is not a but the standard techniques are the push technique and reverse breech extraction or the pull technique, Putberthen's method, and using the medical devices. And what is this push method? The patient is in semi-lithotomy position. After the uterine incision, the fetal head is pushed up from the vagina by an assistant. And while the operating obstetrician applies a deep upward pressure on the fetal shoulder, that also will help to disimpact the head with one hand. The other hand is used to prevent deflection of the head. Very, very important. When the head is deflexed, it will not come up. And the assistant, you always ask them to use a cupped hand. Don't push up the head with 2 fingers. If you use focal pressure, will be more, you can produce fractures to the skull and problems. So always use your hand cupped like this, and then you give uniform pressure. And another modification is abdominal-vaginal surgery. It is, procedure is carried by the surgeon alone. There is no assistant to push up the head. And here the patient is put in bit more position or the frog position. That is exaggerated abduction up to 180 degree. So after making the uterine incision, the surgeon uses his right hand to push up the head from the vagina. With the right hand, he manipulates abdominally, increasing the flexion, and change the gloves and proceed with the surgery. Okay. And Toronto surgeons, they use elastic vacuum cup. And this cup is applied to the fetal head before surgery, and there is no negative pressure. So that is used to elevate the head so that the uniform pressure is applied to the fetal head. And slightly higher transverse, and the method is you put a slightly higher transverse incision and steadily elevating the fetal shoulders. And this time you have to put the patient in deep Trendelenburg position. So put the patient in Trendelenburg and give shoulder traction so that the head can be easily disimpacted. And use of uterine relaxation like relaxants like terbutaline, nitroglycerin there is no standard recommendations, but if you want, you can tell your anesthetist to give nitroglycerin when you are doing all these things, but it is not recommended standardly. And whatever method you are using, you deliver don't be in a panic. You have to be, the surgeon has to be calm and quiet. If you are panic, you are unrest, then the patient, the whole team will become unrest, isn't it? So calm and quiet procedure, very important. Deliver the head slowly, introduce the hand up to the occiput, release the vacuum, and then you slowly go to the occiput, lift the occiput, flex it, and deliver it. That should be the procedure. It will reduce the risk of deep inferior angle tears, extension of vertical tears, etc. That means when you are disimpacting the head, you are right on the right side of the patient, you always use your left hand to disimpact the head. Because when you are using your right hand, when you want to go below the head, you have to extend your flex. When you extend it, this extension movement causes the tear of the lower uterine segment. If you are using your left hand, you are going like this. It's a natural curve. So the extension of the wound will be less. That you have to practice when you do normal cesarean section, how to deliver the head with your left hand, not the first time when you do the cesarean on a full dilatation. Because it will reduce the risk of deep inferior angle extension and vertical tears. In situations where it is extreme difficult, you can extend your incision reversal. And the sequelae of disimpaction. This disimpacted head can increase intracranial hemorrhages, skull fractures, even neck fracture can occur, facial nerve injury, birth with related problems, stillbirth, etc. And maternal injuries, we said, extension of the uterus, uterine incision, injury to the bladder, ureter, uterine muscles, cervical lacerations, etc. And reverse breech extraction of the pull technique. Actually, this was first described by Fong and Arul Kumar in Singapore. The operator's hand is inserted into the uterus towards the fundus to grasp the fetal feet, and which are then pulled down to perform a footling breech. It's just like a footling. And once the feet are at the uterine incision, the delivery is conducted as a typical breech delivery. That is the reverse breech extraction of the pull technique. And if you put a vertical incision, low vertical incision, this will be more easy, but still it is difficult to get into the feet. You can make it an inverted T-shaped incision or a J-shaped incision. And when you put a transverse incision, usually what happens is that one shoulder will come out. Don't get panic. Don't try to push back the shoulder there. Looking at the shoulder, you can see you can assess where is the back. See, when you look at the shoulder, you know where is the back of the baby. Go to the opposite side. You will definitely get the foot of the baby. So it will be easy. And this fetus encephaly presentation is extracted through the uterine incision by pedalic pole. Compared to push method, maternal injuries, blood loss, time taken to deliver the baby, all this will be less with the pull method. And Patworthen's method, all of you know how this Patworthen's method is done. Transverse incision lower uterine segment at the level of the anterior shoulder. Deliver the shoulder first. Then you hook your both fingers to the axilla and with gentle traction, aided by frontal pressure, deliver the body of the uterus, followed by fetal head. This is Patworthen's method. This is transverse incision. Then trying to deliver the one shoulder. And once you get gentle movement, don't use undue force. You may have fractures of the. After then one shoulder is delivered, then you go and deliver the other shoulder. Then both fingers are hooked into the both axilla, and then you give traction upwards, and you can deliver the body, and finally the head also will be out. So that is how you have to proceed with Patworthen's method. Then there is another modified Patworthen's method. Now they are trying to deliver the trunk and the head also. This modified Patworthen's method is usually done for occipital posterior positions, where you deliver one shoulder, then you deliver the foot, lower limb on the same side, other lower limb, other shoulder, and like that. It comes like this. And there are certain medical devices which will help you to disimpact the head. And what is the fetal pillow? You can see the fetal pillow. This is a device used to push up the head from the, because the disimpacted head is pushed up by the fetal pillow. This consists of a, you can see it now. The volume, can you increase the volume? There is a silicone cup with a baser plate and a syringe attached to it. The syringe and the fetal, and then you put the, only 2 minutes more.
Sterile gel or obstetric cream. Hold fetal pillow in the hand with the base plate folded along its short axis. Tube attachment should be facing upwards. The balloon surface should be...
You slowly introduce it into the vagina, and the basal plate is kept below the head of the baby. Put it below the fetal head. Then you Then you make the trachylite and inject 180 ml of saline so that the balloon will inflate.
A total of 180 milliliters of saline should be used for inflation. This allows easier and less traumatic delivery of the baby and reduces.
You can see how the baby's head is gradually getting elevated. So without any trauma to the baby, we can just elevate the head. This is, it is called as the fetal pillow. So other medical devices is a sneeze-knocked and a curved ventilation with multiple ventilation. You can pass it through between your uterus and the fetal head. That will go down and that will release the vacuum, so it will be easy to disinfect the head. And then there are so many spoons. You have seen all these pictures in the books, coining spoons, all these vertical spoons. This smooth, round edges curvely slipped into the uterus. Instead of putting your hand, you put the spoon. You go down beneath it, then you slip it. That is the medical devices. And whatever technique is adopted, once the baby is out, you deliver the baby, always wait for the uterus to contract. Don't immediately sterilize the uterus, because placental separation is very, very important. So once the placenta is separated and delivered, then you sterilize the uterus, completely examine the uterus for any angle tears, extension, all this should be looked into. Be prepared to tackle PPH. Can be traumatic, can be atonic, so every precaution should be taken to this. And when you are suturing, if there is a broad ligament angle tear extending in the broad ligament, always be careful with the ureter when you stitch it up. And more important is documentation and debriefing of the patient and the families. And the need of the day is proper training and residents and junior staff. All of them are going to be future obstetricians. They should be trained to conduct operative vaginal deliveries, then only we can reduce the rate of cesarean section. And reduce working hours and training time may result in less exposure and less confidence in performing instrumental vaginal deliveries. Only after attaining competency in doing cesarean section, go for cesarean at full dilatation. And second stage decision making and procedure should be in the presence of or by a senior consultant. And cesarean section full cervical dilatation can be further reduced by reviving instrumental vaginal deliveries and reducing primary cesarean section rate. Thank you.